Good afternoon to all the delegates and faculty present today. We welcome you to the fifth masterclass in lung cancer workshop organized by the Tata Memorial Hospital. And this workshop aims to keep us abreast about all the latest updates and the role of intervention and imaging in the management of lung cancer. So to avoid any further delay and to begin this event on an auspicious note, I would like to invite Dr. Bhavin Jhankaria, sir, eminent and renowned radiologist and director of Picture This by Jhankaria, Mumbai. Let's hear it for sir.
Every time somebody uses eminent, I know that I'm on my way out. That's why you have to take lectures like this now. Okay, so I'll spend the next about 8 minutes talking about lung cancer screening in India. Where do we stand? And then maybe some questions if we have to. So this starts with the basic understanding of screening, right? Screening is of two types. One is population, the second is opportunistic. Population screening is where the government or the National Health Service or insurance pays or underwrites screening for an entire population that deserves to be screened. So for example, breast cancer screening with mammography in most parts of the Western world, fasting blood sugar estimation for diabetes, screening colonoscopy for colon cancer. These are all examples of population-based screening, which typically occur in rich Western countries. There is no population-based screening in India, not one thing, right? Not fasting blood sugar, not measurement of blood pressure, nothing. So you can't expect radiology or oncology related screening to occur in India. So what does occur is opportunistic screening. That is when an opportunity presents itself to a system, a hospital, a group of people, or to people themselves to be screened or to get screened. Example, people who go for health checkups or physicians sending patients for tests based on risk estimation. So I think you have high atherosclerotic cardiovascular disease risk, and therefore I'll send you for LDL estimation or a calcium score or whatever it is. Or people and patients wanting to test themselves for breast cancer, or gynecologist saying you're 45, go and get a screening mammography done. That is opportunistic screening. So in India, all screening is opportunistic. There is no population-based screening in India. So let's talk about lung cancer screening. Where do we stand? The first thing we have to prove is that it works. And I don't think we need to reinvent the wheel in India for sure. It's been done multiple times across the world. It works. It saves lives. It picks up in high-risk patients, those who smoke more than 20 pack years and actually even lesser, lung cancer at a stage where by treating it, you extend life. So that part works. And we've been doing it for about 10 years. We've published a small proof of concept study, and that hopefully would have led to more studies, but they're not going to happen. It's too late for that anyway. But LDCT saves lives. So why has LDCT for lung cancer screening not taken off in India? Lots of issues. Inertia, just the fact that when you need to start something, you need somebody to push you. We don't have driving forces. We don't have a single person or an association that's decided we will take this up and we will push this and we will try and get people to use LDCT screening. It doesn't work somehow. There are perceived radiation issues, which sometimes in the minds of policymakers are difficult to get rid of. Everybody talks about the endemicity of tuberculosis, which can confound the results of LDCT. But the Korean studies have clearly shown that's not a problem. We cannot underestimate the fact that radiologists are reasonably good at figuring out what is or is not significant. And we should have that faith in the training that we could train enough radiologists to be able to do so. Lack of a smoking history, because we don't have good EHR systems, perhaps the ABDM that has been launched by the government after 5-10 years would allow that to happen. But currently, Patient comes for a CT chest, the radiologist doesn't even know the smoking history. So for the radiologist to push the patient into a screening program by just giving it as an LDCT report cannot happen, because you don't know whether the patient is a smoker or not. So that itself is a problem. And then, of course, while I did say we should have faith in our training of the radiologists, currently the situation is that in anybody, even a 70-year-old smoker with speculated margins, your report will start by saying likely to be of infective benign etiology, wait for 3 months, give antibiotics, some kind of rubbish like that. So there we do need a little more training to kind of turn it around to say 70-year-old smoker with a speculated nodule likely to be malignant unless proven otherwise, and get a biopsy done. And then obviously cost, everything in India boils down eventually to cost. But there are people who can afford, the country cannot afford, and that is the difference between population and opportunistic screening. And then unfortunately, we have these kind of editorials. This is a conclusion of an article that came out that kind of said all of this, that though there are strong shreds of evidence with few limitations, etc., TB, sarcoid radiation, it doesn't work. Another one from Delhi PGI put together, same thing, ideal screening method. This is not because A, B, C, D. But both these sets of authors, the one thing they haven't understood is the difference between population and opportunistic screening. All these statements are made to say that LDCT cannot be a population screening tool. And I agree, it's the same debate. Breast self-examination or clinical examination is as good as screening mammography from a cost effectiveness perspective. Yes, if you were going to use it as a population screening tool, perhaps in a country like ours. But if a woman who earns a lakh of rupees a month wants to get a screening mammogram done because the data is that it saves lives, you can't deny an opportunistic screening to somebody who can afford to get it done. And that we always mix up and mess up. And that's where the problem arises. So India cannot afford population screening for any disease at this stage. We don't have it. We can't even do blood pressure and fasting blood sugar. And those two are the biggest killers in India. Forget oncology. That comes really, really low down on the list. So if all screening in India is opportunistic, then opportunistic screening is not difficult. And that is something we need to work on. So what are the things that we can do right away? Every physician who sees someone with a 20 or even 18, 17 pack years history can advise an LDCT study. Patients who can afford will get it done. During COVID, we made 50% of the country get CT chests done. We can do this. It's not possible. Every hospital can institute an LDCT program, make brochures, standees, etc., give them to patients, to people in the rooms. It's all doable. All diagnostic centers and hospitals that offer health checkups can create a package saying smokers package or high-risk lung cancer package. And like you put calcium scoring now as part of a health checkup or cardiac CT, put an LDCT. No? That's also doable. Whenever a radiologist reports a CT scan in a smoker, if you see emphysema and you don't even have the smoking history, use an LDCT report format and then use a lung RADS and put the patient as part of screening and say, as per protocol, next screening is after 1 year or 2 years or whatever it is. Automatically, you've created a cycle whereby even if 20% of those patients look at a date and come back for a follow-up, you've instituted an opportunistic screening program. And the same for all those who do tobacco and de-addiction programs. They should also start doing this. That's pretty much it, right? So we should start small, but at least let's start. I mean, it's been 10 years since we started and that's it. We're still the only ones doing it. And it sucks. I think there is a lot more that we can do. It saves lives in smokers. And I think that's something we should be doing. Thank you so much. So questions, we have time for a couple questions.
What is your opinion on screening of D3 or D4 in in the sense that how much of the CAD calcification should it go from the non-gated scan? Does that add, like,
Yes, we report. So just calcium, no calcium is good enough.
It says at least mild, moderate, severe.
Yes. Yeah. So we are using AI to actually quantify. It works really well.
Even for the non-gated.
Even for non-gate. Yeah. But in the end of the day, it's just no calcium. Yes, calcium. That's good enough. So we do that. Okay. Sure.
Thank you so much, sir, for giving us the roadmap on how to start lung screening in India. And now I invite Dr. Ashu Seth Bhalla, Professor of All India Institute of Medical Sciences in Delhi. She is a great propagator of academics and promotes thoracic imaging as far as possible. So, ma'am, please.
I have to open here on my own. This transition is not occurring from here. No? You want me to use this? Okay. So after Bhavin has told you that you should look for lung cancer in people who have been smokers, we'll briefly touch upon when do you suspect lung cancer and several things more about its imaging spectrum. So what happens is that lung cancer can have a typical appearance and an atypical appearance. So it's not only, asymptomatic people in whom you are doing an opportunistic screening. Mostly we will be confronted with people who are symptomatic and we have performed imaging of any sorts. And here the issue is that the symptoms of several things, including tuberculosis, infections, other infections, and CA lung can be similar. So there are so many mimics that are enlisted. I've divided these imaging spectrum into two types, which is to say that this is a classical appearance and this is an atypical or less frequent appearance. Obviously, when the appearance is atypical or less frequent is the time that you are likely to miss it and call it something else, which leads to delayed diagnosis. Broadly, the classical appearance divides it into central and peripheral tumors. From a teaching point of view, what is the definition of a central tumor? Up to the segmental bronchi. So which means main lobar segmental and inner 2/3 of lung remains central and the rest beyond that are called peripheral. And from clinically, what can central tumors come to you like? They can come to you like a hilar mass. They can come with a central mass with a distal collapse, or simply that the collapse is the dominating factor. Like here, it comes with an opaque hemithorax. So this is the classical appearance of central masses. And this is the CT scan illustrating pretty much the same, that you have a hilar mass, you have a lot of mediastinal nodes. When we come to staging, Mandeep will address how differentiation between central masses and nodes can be challenging. And similarly, you have distal collapse. So this is the typical appearance for a central mass lesion. In peripheral tumors, the story becomes more diverse, especially since the screening programs came. Earlier, we would refer to them, solid masses with speculated appearance and pleural tags, etc. But with early lung cancer, there is a lot of emphasis on part solid nodules and features in part solid nodules, which should help you detect malignancy. So there are many features such as pseudo cavitation signs, bubble sign, etc., which should help make you suspect that this is malignant. So this is example of an air bronchogram, which is otherwise classical of infective consolidation and cavitary mass, which are easy to mistake for infection. So these are the classical picture that we are used to. But now I'm going to address the issue of once having diagnosed CA lung, as we move into the era of radiomics, how much machine-based feature extraction or human being based can actually help in subtype prediction. And is subtype prediction your role at all? So it is actually, because as you would have seen, even after the histopathology, many times the histopathologist can also have a dilemma. So it does help to say that if you can predict the subtype, the first main subtype prediction is differentiating the epithelial from the neuroendocrine variant, which means is it NSCLC or is it a small cell carcinoma? So the first differentiating type is differentiating small cell versus non-small cell, which is summarize some of the points that I brought out. One, what famous is that you have a small peripheral tumor and you have huge mediastinal nodes. But that's not the only thing. The small cell tumors, when they are peripheral masses, do not show speculation very often. I'll show you another sign which is seen with small cell carcinoma, which is the peribronchial spread. If you see this case below, the peribronchial spread, which goes along the central bronchi, is very characteristic of small cell carcinoma. On the other hand, pleural spread is very infrequent with small cell carcinoma. So this is the main, first step towards, say, subtype. Then the next step comes, can you tell an adenocarcinoma versus a squamous cell carcinoma? We are aware that cavitation is classically described more in squamous cell carcinoma. We are now on peripheral tumors because central tumors are really difficult to tell. On the other hand, presence of air bronchogram, bubble-like lucency, pseudocavitation, and part solid nodules are characteristic of adenocarcinoma. So the fun differentiation you did was squamous versus adeno. So here are some examples to show you the differentiating points. Squamous has the characteristic peripheral thick-walled mass-like lesion. And then, but look at the spectrum that the adenocarcinoma can show you. Part solid nodules, small bubble lucencies inside, and then large areas of consolidation, cavities with just a little extrinsic wall thickening. The last one is a patient of invasive mucinous adenocarcinoma. So this was differentiation between adeno and squamous, but that's not the only differentiation. Now I'm going to go further into the subtype differentiation. Now, if you look at the WHO classification, we divide the adenocarcinoma into pre-invasive, minimally invasive, and then overtly invasive. Apart from, even in the pre-invasive, the moment you start from adenocarcinoma in situ or AIS, the mucinous versus non-mucinous categories start. So can you predict mucinous versus non-mucinous? And then I will come to the various grades of invasion that you can predict on imaging. So if we come to subsolid nodules, you know that nodules which show you a mixed solid plus ground glass component have a higher chance of being malignant. And as the solid component goes up, so does the likelihood of malignancy. And several of these pre-invasive and minimally invasive lesions may not be PET avid. So that's the need to, recognize them early and sample. So if we look at the grades of invasiveness and how the appearance will change. So from the first category is AIS, then minimally invasive, and then at the other end is invasive mucinous. In between are lipidic predominant or called LPA. So I've given two examples of MIA on top and LPA at the bottom. So the MIA can look like, a purely solid ground glass also with hardly any ground glass nodule with hardly any solid component. And the one which I've been showing you throughout with pseudocavitation was a lipidic predominant. Pseudocavitation or bubble lucencies are characteristic of the lipidic pattern of growth. Now, if you look at the next one, this one is the one which, is most likely to be missed because this will come as multiple nodules, consolidation. And especially if you do an MR on them, this really bright T2 hyperintensity. And now we are so familiar with this entity that whenever we see somebody who's 30 something and has a non-resolving multifocal consolidation, we say, is there bronchoria? This is mucinous adenocarcinoma. Most likely these are mucinous adenocarcinomas. So next differentiation that you can do is mucinous versus non-mucinous. So if you look at the differentiating points of mucinous versus non-mucinous, air bronchograms, bubble lucency, CT angiogram sign, because like if you see in the previous patient also, which I showed you, this is a non-contrast scan. If you do contrast enhance, these consolidations of very low density, and the CT angiogram sign really shines out amongst them. So this pattern of mucinous is also very easily predicted on imaging. This is another example of mucinous adenocarcinoma, and which happens in young people more often, and several of them are non-smokers. But this patient also has a left main pulmonary artery embolism or thrombus consequent to the malignancy. So this is the next step that you can predict. Can you predict the driver mutation? So you know that now radiomics are focusing on, if you look at the spectrum that we get in India of advanced NSCLC, all the studies and whatever data we have analyzed of our CT and PET, we have not found anything significant. And most of the literature, talks about differentiation in early stage lung cancer. In advanced stage, it's very difficult to predict the driver mutation. Although, overall, when these are EGFR positive tumors, then hematogenous spread is more frequent, lymph node metastases are less frequent, but it's difficult as of now, at least in advanced carcinomas, to predict EGFR or ROS mutation. And so that is, now I'll come to the next thing, which I told you of missed lung cancers, that atypical appearances. We've seen some typical, we've seen some subtyping. So this is a patient in whom was a regular follow-up patient, but we missed the lung cancer. So I always carry it. It was a mistake made. This is a 75-year-old patient who was on UIP follow-up. And I zoomed these images out because we made the diagnosis when the last scan happened in July 2018, and we sampled and it came out as squamous cell carcinoma. But actually, if you look at October 2017 compared to 16, we should have predicted it at that time, because there was a bit of eccentric wall thickening which was beginning to happen in the anterior wall in October. And unfortunately, the interim 1 year, not even 1 year, 10 months that it passed, it became an advanced lung carcinoma because patient had huge mediastinal nodes. And he was on antifibrotics. So every year we were almost doing a scan on him. So this is the classification, one of the commonest missed lung cancers are cystic airspace associated lung cancers. And there's a classification of the patterns by Masachi et al. You can go through that in detail of various types of appearances which come. And one more such example, this is not really cystic space. This is like a patient who kept getting treated like a ruptured hydatid for long till patient came to us. To be fair to them, initially the pleural thickening and wall thickening was not so gross, but the moment you look at it, this is CA lung, and this is a patient we did last month, and it did come out to be adenocarcinoma eventually. So cavities and cysts are one of the commonest reasons of missed lung cancer. Another patient we missed about 15 years back. She was also being treated as tuberculosis for long. Now we know that these are, bubble lucencies. Over a period of time, this cavity wall kept on thickening, and she came with anterior abdominal wall metastasis. She was a scientist with us, 36 years old. So cystic space associated lung cancers are one entity which are missed. The other entity you tend to miss are scar carcinomas in setting of silicosis, in setting of tuberculosis. So scar carcinomas also you need to, watch out for. Whenever you have an increase in size, increase in ground glass, new speculations, you have to be aware. So to summarize, what radiomics promises to offer and what you can with human reading offer currently is benign versus malignant differentiation, predicting a mucinous adenocarcinoma, predicting the degree of invasiveness and histological subtype, and identifying high-risk lesions, of course, in LCS setting. I have not put the driver mutation here because I don't think we are there yet. So thank you very much. Questions?
Thank you so much, ma'am, for telling us how varied the appearances of lung cancer can be. Next, we invite Dr. Mandeep Garg, Professor in Department of Radiodiagnosis, PGI, Chandigarh. So, please.
इसी से आएगा नहीं? Okay, so after hearing about the insight into lung cancer screening and then the various radiological patterns of lung cancer, let's see how to stage the lung tumors. So as all of you know that we use TNM staging for lung cancer, and TNM is an established uniform method of staging, and it depends primarily on the anatomic extent of the disease. It not only helps in treatment planning, it also provides us some prognostic insights, and it facilitates the uniform exchange of information across the various treatment centers and treating physicians. So currently we are into 8th edition of TNM, which was released in 2017 by International Association for the Study of Lung Cancer. And the main updations in this 8th edition over 7th edition were related to the tumor size and extent of involvement, which was in the T stage, and then subclassification of extrathoracic metastasis in M stage, while the N stage remained unchanged between 7th and 8th edition. So the terminology used in TNM staging is most often the CTNM, which is clinical TNM, or also called ITNM or imaging pre-treatment staging. And sometimes we also do use the word PTNM, which is pathological or surgical staging. And then YTNM when we stage the tumor after the completion of the therapy, or when we stage the tumors when there is recurrence. This is called RTNM. So CT scan and PET-CT, they remain the main imaging tools which are used for TNM staging. So let's start with the T descriptor first. So T descriptor, as they say, that every centimeter counts. It depends upon the tumor size and the extent of involvement. And remember that in the 8th edition, there is separate criteria for solid, subsolid, and multiple tumor nodules or lesions when we give the T descriptor. So this is the chart showing the T descriptor in various categories. I think all of you must be aware of it, and I need not go into the detail of each of these subcategories. Just remember that the T staging is given based on the size, which is measured in centimeter, which is the largest dimension measured on lung window, and the extent of involvement of the adjacent structures by the tumor. So I will be discussing only about the contentious issues, or where there are certain discrepancies, so that we can understand better. Whenever there are certain tumors when multiple T descriptors are applicable, in such cases, we need to see that we have to, the highest T category has to be chosen to give the T descriptor. For instance, this is one example. There is a FDG-avid tumor sitting here with associated collapse. So if you go by the size criteria, the largest dimension of this lung lesion is approximately 1.5 centimeter, which will make it as T1B, because the size is between 1 and 2 centimeter. But however, if you look at the associated atelectasis, that will make it as T2. So as I've told you, that when there are multiple T descriptors applicable in any one patient, we have to choose the highest T descriptor. So in this patient, we will use the T2 stage for TNM purpose. Also, on surgical and pathological review, it has been found that CT scan often overestimates the tumor size, and there can be inter and intra-observer variations while measuring and reporting the size of lung nodule on CT scan. And many other technical and patient-related parameters are also need to be considered, such as slice thickness, the reconstruction kernel, patient's level of inspiration at the time of scan acquisition. So these also contribute in the variation of the reported tumor size on CT scan. In addition, certain lesions can show central necrosis or cavitation. They can have ill-defined margins. They can be associated post-obstructive pneumonitis or radiation changes in the surrounding lung, which can pose a major challenge even to the most experienced radiologists while accurately measuring the tumor size on CT scan. So for instance, this is one example. Here you can see there is a tumor sitting here in the right lung, which shows a lot of speculations and some atelectatic bands. In addition, you can also see this band-like atelectasis anteriorly. So many a time that it poses a great challenge, how to accurately measure the largest dimension. And these kind of lesions very often show inter and intra-observer variations. Then the next pitfall comes in the measurement of subsolid nodules. In part solid tumors, which can be either subsolid or pure ground glass, as Dr. Ashu had shown you in many examples in a previous lecture, the solid component many times is very difficult to measure, especially when there are multiple complicated or scattered solid areas rather than a single focus. And there exists no consensus as to how to make the measurements uniform to measure this size. And this is, for example, this is one case where you can see that there is a part solid tumor which has multiple lobulated solid nodules within it, and we do not know which nodule to measure. Should we measure the entire this thing, or we have to measure separately these tiny lobules of these solid lesions within this part solid nodule? Then moving on to end descriptor, there is no change from the 7th edition. And any lymph node which is more than 1 centimeter in short axis diameter on CT scan is considered abnormal. And primarily, it is a structural location of the involved lymph nodes based on which we give the end descriptor on CT scan. So this is the class. There's a table showing that N0 stage means there's no lymph node metastasis, N1 when there's ipsilateral, peripheral, intrapulmonary or hilar nodes, N2 when there is ipsilateral mediastinal, subcranial nodes, and N3 when there is ipsilateral, contralateral, supraclavicular or scalene lymph nodes, or contralateral, mediastinal, hilar or peripheral lymph nodes. So there are a few limitations even when we are evaluating the lymph nodes and staging, giving N descriptor for the TNM staging. As I've told you that any lymph node which is more than 10 millimeter in short axis diameter is considered positive based on CT scan. However, it has been found that a significant number of nodes which are smaller than 10 millimeter can be malignant, and so are the nodes which are more than 10 millimeter reported to be benign. So to take care of this discrepancy, FDG PET comes to rescue to some extent, and it has been found that sensitivity and specificity is significantly increased when we use FDG PET to stage the lymph nodes. But even on FDG PET, there can be false positive nodes, especially in TB endemic regions like India. So the inflammatory nodes will also show increased FDG activity, and thereby leaving us with no option but to go for invasive mediastinal staging. Then another issue with the current TNM staging is subcranial lymph nodes. Should we label it as N1 or N2 disease? Because if we follow the Neruke Japanese map, it defines a subcranial lymph node as station 10, which makes it as N1, while the American Thoracic Society describes subcranial node as station 7, which is N2 stage. And if you see that in 8th TNM, the majority of the data based on which this TNM staging was proposed has been collected from Japan, which uses this Neruke Japanese map. According to this Neruke Japanese map, the lymph node involvement of subcranial space is labeled as N1, and while the American Thoracic Society labels it as N2. So to overcome this discrepancy, I think all of you must be aware of this lymph node station, which is a unified international lymph node map given by IASLC, so that there is no ambiguity when we classify the lymph nodes when we use this international lymph node map. In addition, there are a few more features which are not addressed in this 8th TNM staging, like if the lymph nodes have irregular margins, and especially when there is non-regional thoracic lymph node involvement, like lymph nodes in the axilla, subpectoral, internal mammary, or diaphragmatic regions. And some authors suggest that all these chains should be taken as M1 disease, while others say that it should be N3 disease, especially the axillary chains. So further clarification and consensus statement is still awaited on these kind of lymph nodes. So moving on to the M descriptor. M descriptor is basically for metastasis. M0 when there is no distal metastasis. M1 further divided into M1A, B, and C. M1A when there is intrathoracic metastasis or any pleural or pericardial effusion or contralateral lung nodules or pleural nodules. M1B when there is single extrathoracic metastasis in a single organ. And M1C is when there are multiple extrathoracic metastasis. And this is the stage groupings based on the 8th TNM after we give T, N, and M categories to a different, to a particular scan. So there still are many challenges ahead in this 8th TNM staging. Moving on to pleural invasion, there is no way and no absolute criteria by which we can identify the pleural invasion, and we cannot differentiate based on CT imaging whether visceral or parietal pleural invasion is there at clinical staging. And the only CT finding which is considered confirmatory for chest wall invasion is the destruction of the bone. Then the present database used in 8th TNM does not provide any information on immunohistochemistry and molecular genetics, such as EGFR mutation. Then we also need to consider the presence or absence of driver oncogenes and immune status, which is again missing in this 8th TNM. So the prognostic impact is limited based on the 8th TNM staging. Then another issue with 8th TNM is when we see incidental pulmonary nodules, we do not know whether these are metastases, whether these are synchronous or metachronous lung tumors, or these are benign lesions. So the diagnostic dilemma continues when we see these kind of incidental pulmonary nodules. So what is the way forward? Way forward is the 9th TNM. Let's see when it is expected and what are the expectations in the 9th TNM. So data is already being collected to inform the 9th edition. In fact, most of the institutes have already provided their data, and this 9th TM is scheduled to be published in 2024. So many new data elements such as patient-based, environmental-based, and tumor-related factors like genetic biomarkers, protein alterations, and copy number alterations have been added to stage the tumors for the first time. And many international collaborations are done to build a large and detailed database to achieve such objectives. So to conclude that imaging plays a pivotal role in staging the lung tumors, and radiologists must be familiar with the 8th TNM system and its pitfalls so that we can establish a fairly accurate communication with the referring physicians, and further collection of prospective data and detailed attention to unanswered questions will guide the developments for future staging systems. Thank you so much. Any questions? Thank you.
Thank you, sir, for giving us the updates in staging of lung cancer. Next, we invite Dr. Rajiv Kumar Kaushal, Professor of Pathology, Tata Memorial Hospital. He'll be joining us virtually to give his talk.
Thanks, Amit, for including me in this workshop on radiology. And can you see my screen? And am I audible? Am I audible? And can you see me? See my presentation? Should I start my presentation? Can you see my screen and am I audible? I hope I'm audible and you can see my slides. Can anyone confirm that?
Yes, sir. Visible, sir.
Okay, thanks, sir. Just waiting for the confirmation. So I'm and sorry for the delay if it has happened, because I thought there is a communication gap. So I'm going to talk about the new updated histology and targeted mutation in lung cancer. As we all know, that we have moved a long way ahead from the traditional view of the lung cancer, where it was just a non-small cell carcinoma and small cell carcinoma. Now the definite histological characterization of the lung cancer is mandatory, and that is not only restricted only to the histological classification, but with the evolving genomic classification now, the further molecular subtyping of non-small cell carcinoma is also very much relevant. Hence, a tissue which when a radiologist give us this tiny, very precious tissue course, they have to move ahead with the basic histological class subtyping, for which IHC markers are required, and followed by the molecular classification of the tumor. And there are many modalities in which we can explore the genomic profile of a tumor. So these are the various types of the specimens which we come across, and in which we have to offer it, not only the diagnosis but complete genomic profiling. And as you can see, these tissues are very tiny, and many times it becomes a very crucial for the treatment decisions. Hence, the role of an intervention radiologist and a close interaction with them is very much relevant, because the handling of these tissue right from their retrieval is very crucial. And as a pathologist, we have to act as a guardian of these tissues, so that we can provide a maximum information to the clinician. And last year, the new WHO classification of thoracic tumors was published, and in this new edition of WHO classification, there are largely there are structural changes, but there are some new sections, and especially about the molecular diagnostic assays were included, and some new entities were also introduced. I'll just briefly touch upon those. So this is in brief about the various classification of the lung tumor, right from the malignant benign epithelial tumors to the malignant epithelial tumors, in which adenocarcinomas are the most common. And it's not only the adenocarcinoma now, the further subtyping of the adenocarcinoma is also very much relevant based on the histological growth patterns. And so the WHO classification of the lung tumor, as I said, mentioned that in adenocarcinomas, we have to try to make an attempt to further sub-categorize into the further types. Squamous carcinomas, they can be keratinizing based, or non-keratinizing. Another two types of squamous carcinoma, it can be either basaloid or lymphoepithelioma like carcinomas, neuroendocrine tumors, and large cell carcinoma. They are the other subtypes of the tumor which we regularly encounter in the lung. Large cell carcinomas, the diagnosis should be restricted only to the resection specimen and should not be offered on the biopsies. And these are the other subtypes of the tumor. So whenever we deal with these in these cases, we have to make an attempt to give a more precise diagnosis rather than giving a non-small cell carcinoma, and to restrict the use of non-small cell carcinoma as minimum as possible in the routine practice. And how we can do that? We can do that with the use of judicious use of ISCs. So ISCs should be used in lung when you're dealing with a lung tumor, but their role should be judicious, and with the idea that we have to save the tissue for the further molecular testing, because the treatment decisions is not based only on the histological diagnosis but also on the molecular profiling. So if there's a clear-cut squamoid or glandular differentiation is present in any case, then in those situations there is no need to further do the immunohistochemistry. And but if on morphology, especially if you're not sure, so you can see that these are the very tiny tissue bits which we deal, and we have to offer diagnosis and also the molecular subtyping. So in these situations, a limited ISC, like in this case a tumor, we are not sure whether it's squamous or adeno, but TTF1 proved it to be adenocarcinoma. So these are the few subtypes in which essentially we have to do the ISCs. In other cases you can avoid it, and the percentage rate of non-small cell carcinoma NOH should be as less as 10%. So as I mentioned earlier, the adenocarcinoma, although not is the one of the common histological subtype, but it can show the heterogeneous growth patterns, and it is important, especially in the resection specimen, to comment which type of growth pattern the tumor has. Why it is important? Because it also decides the prognosis of the tumor. So as compared to the lipidic and acinar tumor, solid and micropapillary tumors has a adverse poor prognosis. And now the new WHO classification also supports that the grading of the tumor should be based on the pattern of predominant pattern along with the degree of differentiation, and the three-tier grading system for the adenocarcinoma is proposed, in which if it is a lipidic, it will be a grade 1 tumor, but if it is a poor growth pattern, that means micropapillary is solid or complex glandular pattern, these are called as a adverse poor high grade pattern. So those are going to behave in a more aggressive fashion. Next common category of the tumor is squamous carcinoma. So in this keratinizing, non-keratinizing the types are there. So if it is non-keratinizing, in those situations we have to do the immunohistochemistry for the confirmation. The lymphoepithelioma like carcinoma is the new entity which was proposed in the new WHO classification. So these tumors are EBV related and likely to show the good clinical outcomes. There's another entity which is presumed to be a subtype of poorly differentiated squamous carcinoma, is a nut carcinoma, which is characterized by a specific genetic alterations, and ISC for nut confirm the diagnosis. So the sinonasal tract and the mediastinum or the hilar region is the common type of site for these tumors. Another entity which is introduced in the new WHO is a SMARC A4 deficient tumor. So these are the tumors which are undifferentiated, usually don't express any markers, but show the loss of BRG, that is the SMARC A4. So this tumor has come as a new diagnostic entity in the recent WHO classification. So these are about the primary lung tumors. Briefly about the tumors of the pleura and the mesothelial tumors are the common one, and in which mesothelioma can be epithelioid, sarcomatoid, or biphasic type. One important thing is which is mentioned in the WHO, that there is no need to call mesothelioma as a malignant or benign, because mesothelioma itself is is a malignant entity, and there is no need to add the term malignant mesothelioma in front of it. The confirmation for the mesothelioma, we need ISCs, and it need to be proven, and we have to do at least 2 mesothelioma marker and 2 carcinoma marker. So use of single marker is not recommended. So every time if you're suspecting a mesothelioma, you have to minimum do the 2 ISCs. And there are some 2 additional tests which can be used for the characterization. That is, one is the BAP1 and CDK and N2 fish, or the P16 homozygous dilation, that also helps to the in the confirmation of a mesothelioma and to differentiate it from the atypical mesothelial proliferation. So even if as a pathologist, if you're not certain about the diagnosis, and even especially on the core biopsies, always try and contact your radiologist. And the case which might be very challenging for you on the biopsy can be very straightforward on the radiology, especially when you're dealing with the mesothelioma. So these are the just few summary of some changes which are proposed in the new WHO classification for mesothelioma. We in a similar way as we do it for the lung adenocarcinoma, we have to mention about the various histological patterns. Cytological, there are some mesothelioma which are cytologically high grade. So it is essential now to grade the mesothelioma into low and high grade subgroups, because they have a different clinical outcomes. Sarcomatoid mesothelioma, they are clinically more aggressive as compared to the epithelioid mesothelioma, and there is some high-grade tumors like pleomorphic mesothelioma. They were now clubbed along with the sarcomatoid mesothelioma. So it is essential now as a pathologist, we have to grade the mesothelioma, and for epithelioid mesothelioma, it is also recommended to mention about the growth patterns. Next group of tumors in the lung is a neuroendocrine tumors, and largely there is not a significant change in the new WHO classification for the neuroendocrine tumors, but the grouping of these tumors has now become more much better, because small cell and large cell neuroendocrine carcinoma, they are categorized as a neuroendocrine carcinoma, whereas the carcinoid tumors comes under a category of neuroendocrine tumors. So there is some attempt to make it more uniform as for the other sides. So carcinoids and atypical carcinoids, the terminology is still used in the lung, and at other side we use the neuroendocrine tumors grade 1, grade 2, and grade 3. So these in this WHO still the terminology is continued. Role of MIB1 for categorization of neuroendocrine tumor, it can be done but not mandatory, because it is not the diagnostic criteria. But usually the carcinoid tumors, they show a low expression for Ki67 as compared to the large cell neuroendocrine carcinoma and small cell carcinoma. They show high MIB1 proliferation index, but it is not mandatory criteria for categorization. Some new entities were also included in the neuroendocrine carcinoma, like carcinoid NOS. If you are not able to distinguish between atypical and typical, especially on the small biopsy specimen, you can use the terminology carcinoid NOS. And carcinoid tumor with elevated mitotic activity and proliferation, if the morphology is still fitting with the atypical carcinoid, you can use this terminology. In addition, for neuroendocrine tumor, also now there is a role of molecular subtyping has been come, and similar way as we see in the adenocarcinoma, maybe in future we'll see more and more further subtyping even of small cell carcinomas into the molecular subtypes. So after we deal these evaluation of your histopath report on the small biopsy specimen, we have to give a comment upon the tumor content, because that open the journey for the molecular testing. And as we know, in the lung there are multiple now genetic alterations are well known, and out of which EGFR, ALK, and ROS, they are the common one, but there are, in addition to them, there are multiple additional biomarkers also which we need to test, and they are not they are also recommended by NCCN guidelines to test for them in the routine diagnostic assay, and there are various platforms are also now available to test for them. These are the common modalities which are being used for testing of these genetic alteration, right from the FISH, ISC, PCR, and next gene sequencing. The recommendations for testing for molecular biomarker testing in the lung is essentially to test for EGFR, ALK, and ROS for in all. If you want to test beyond that, then multiplex testing is recommended, and it can be tested on any non-small cell carcinoma, which is advanced stage cancer. And so another role of a good intervention radiologist comes when we are dealing with these samples about how much tissue is sufficient. So these are the various tissue requirements for these various tests which you perform. So as you can see that all these tests need a lot of tissue. So if you give us a good amount of the tissue, we can perform n number of tests, and multiplex testing using NGS can give information about a lot of these biomarkers simultaneously, but the limitation of that is it is expensive, although it is a good give lot of information, but at the same time it is relatively costly, and it need more expertise, and it takes more time, so clinicians might not be ready to wait for them. And finally, even if the patient, some of these patients who are detected for this molecular alteration, they also shows a progression, and these patients, when they come with the progressive disease, then again the role of pathologist also comes to look for the reason for the resistance, and why it is again essential, because a lot of new drugs are also available. So the clinician has many options, and due to the availability of these various genetic alterations. So the role of pathologist in the lung cancer management has evolved to a great extent, and we have to act as a guardian of these precious samples, and a close collaboration with the radiologist is very much essential. If we have to provide a comprehensive report and diagnosis, which is going to help the patient and the clinician at the end. So IHC based biomarkers and NGS will become very routinely, and hopefully the cost of these tests will come down, and many patients will be able to afford them. So these are the various modalities which are available in the current era to the pathologist, and but with these great new techniques, it comes a great responsibility, and the most important I can again want to emphasize is the tissue which you intervention as an intervention radiologist which you provide to us. Thank you very much, and if there are any questions, I will be happy to answer them.
Thank you, sir, for explaining the role of pathology in diagnosing and characterizing different types of lung cancer. We now welcome Dr. Sayak Chaudhary from Nuclear Medicine of Tata Memorial Hospital to give us an idea of nuclear medicine imaging of lung cancer.
Hello, everyone. Is it like sharing the slide? Oh, okay. Hello, everyone. So I'm a bit sorry for being late. There was a huge traffic. So my topic is metabolic staging of non-small cell lung cancer. So the topics that will be reviewed here is very basic things, basics of FDG PET, how the imaging is done, and role of FDG PET in determining T, N, and M staging, available evidence, and pitfalls. So we'll see some images and some ancillary findings of it. So what is metabolic imaging? So we do the modality is PET, and the pharmaceutical is used FDG PET. So how it gets localized? It's a glucose It's a marker for increased cellular glycolysis. That is, cancer cells demonstrate a Warburg effect where they show increased glycolytic pathway, anaerobic glycolytic pathway. So glucose as glucose gets localized, FDG also gets localized through the GLUT transporter. Then hexakinase acts upon it. So FDG becomes FDG 6-phosphate. So now it is a polar molecule and it cannot escape from the cell, and that's how it gets trapped. And most of these cells are also deficient in phosphatase enzymes. So it's a pretty irreversible step. So the activity we inject is 3.7 to 5.2 megabecquerel per kg. And after 45 to 60 minutes, we take a scan. So these are this is the patient preparation that we follow. And staging we all know, and I'll not go into detail. NCCN recommends PET-CT across all stages of lung cancer because PET-CT unearths at least 20% occult metastasis depending on the stage all over. So it is important. So regarding T staging, CCT is the imaging modality of choice, as we all know. And FDG PET performed along with contrast enhanced CT. Then the integrated imaging study has similar accuracy as CT alone. And FDG PET-CT can accurately delineate the viable tumor from surrounding atelectasis. And so what I meant is this. So you can see there is a mass that is infiltrating left main bronchus, and there is surrounding atelectasis and collapse. So in the CT, it is not very well demarcated where the cancer actually stops. So, but with PET, it is very nicely seen. This kind of fusion scans are very easy for radiotherapy people for RT planning, because they can see the metabolically active volume of the disease where they can target it as their GTV. So this is another case where there is hilum is infiltrated and there is a huge area of consolidation and collapse, but the bulk of the tumor is small. So this is another where, so this is obviously a T4 stage, a T4 disease where there is a gross infiltration of mediastinum, but also you can see there is uptake in this vocal cord. So unilateral vocal cord uptake. So here by seeing this, this image only, you can say that recurrent laryngeal nerve will be involved, but many times this paramediastinal tumors might be very small, but you will see that unilateral vocal cord uptake, and the ipsilateral vocal cord will not show uptake, but the contralateral vocal cord will show uptake. So this implies that on left side there is vocal cord palsy, and on the right side there is compensatory uptake in the precarotenoid joint and also in the vocal folds. So regarding nodal staging, so morphological criteria for nodal staging is based on size. More than 1 centimeter in short axis is considered as significant. However, it is not enough because it has a very low PPV, around 50 to 56%. PET-CT has higher sensitivity and specificity than CT in staging mediastinal lymph nodes. So this study from 2006, it's a meta-analysis. So it showed that FDG PET-CT has a sensitivity specificity of 85% and specificity of 90%. However, that study also showed that PET-CT has a lower specificity as compared to CT in nodes greater than 1 centimeter in short axis. So in conclusion, size and uptake both should be taken into consideration. So we'll go a bit detail on the available literature because this is important for nodal staging. So there have been a lot of prospective trials. So I'll list few trials. I have listed a few trials here. So this is a busy slide, but what is important here is see the values. So we all know how you do nodal staging in CA lung. You do nodal staging, the gold standard is mediastinoscopy and biopsy, or now we are also doing EBUS and TBNM. So if a non-invasive diagnostic modality has to be effective, it has to have a very high sensitivity for detecting occult nodal metastasis. So here you can see various sensitivity specificity in these prospective studies. So it is barely approaching 90%. All are pretty low, even though they are higher than CT scan if you compare them, but they are still pretty low. So this has to be thought about. So this study is interesting, where they saw that in clinically N2 disease by medianoscopy, they have FDG PET was initially negative, but 2.9% to and 3.7% cases they with medianoscopy, mediastinoscopy and endoscopic ultrasound, they found disease. And if it is clinically N0, then they found like 17.6%, the 23.5% cases, that basically this is false negative. So that we have to understand. And in terms of Indian scenario, so this study was done in our department, 391 patients retrospectively analyzed, and we also saw similar result. Sensitivity was 72%, and PPV was also pretty low. So that is expected, because in our population, infections and granulomatous diseases are high, so PPV will be low. But to summarize, higher sensitivity to CT scan alone, however, still lower sensitivity, and it cannot obviate the need of EBUS, TBNA, or mediastinoscopy. However, it may guide EBUS sites, like where you can take needle aspiration. So some imaging examples. So this is a tumor in right upper lobe, and you are seeing a subcarinal and right lower paratracheal node. So this is like a T2N2. So another tumor here, there is some consolidation. So this is also a T2, and you are seeing bilateral hilar and mediastinal nodes. So this is a N3 disease. So now coming to M staging. So incidence of distant metastasis in NSCLC varies from 18 to 36% depending on the staging and all. And the commonest site of distant metastasis are adrenal gland, bone, liver, brain. And PET has the ability to detect occult metastatic disease in approximately 29% of cases. So this is one prospective trial that I have quoted. So here they saw that in stage 1, 7.5% cases, they found to have occult metastasis, while it increased to 24% in stage 3. So that is expected. So now we'll go through different sites of distant metastasis and how they may look. So adrenal metastasis, these are also pretty common, and FDG PET has a good sensitivity specificity for detecting adrenal metastasis, and it may also obviate the need for biopsy. So, but FDG uptake can sometimes rarely be seen in benign conditions like adrenal hyperplasia, or even sometimes in secretory adenoma. So those things also be taken into account. However, in those kind of cases, the uptake is, the glands are normally diffusely enlarged, and the uptake is usually diffusely increased bilaterally, symmetrical in nature. And if it is an adenoma, secretory adenoma, and it is showing FDG uptake, the uptake more often will be lower than the liver background, or it will be pretty low, and it will not be more than the liver. So if we see this kind of uptake, then probability of the metastasis probably is low. So in our department, what we follow is very typical. So if we see adrenal nodule, and if HU in NCCT is less than 10, then obviously this is lipid containing adenoma. If the HU is more than 10, then either lipid poor adenoma, metastasis, or any other pathology. Then we'll look at the FDG uptake. If it is focal intense FDG uptake unilaterally, then metastasis is more likely. If it is equivocal or negative, then and if there is no other distant mets, then we may consider, then we may ask the clinician for biopsy. So we are I'll show you some imagings. So here, so you can see there is a adrenal nodule. It is not very big, but it is showing more uptake than the liver, and this was positive. This patient actually had gross metastatic disease, but I was just showing the adrenal lesion. So another nodule. So these nodules can be this small, but when you see in the MIP image, or also in the PET image, many times in the fused images, it is very, sometimes it might be difficult to understand, but in the raw PET image, you can see that the uptake is definitely more than the liver. So bone metastasis, FDG PET is the best modality to detect occult skeletal metastasis. In this meta-analysis, they showed that FDG PET has a sensitivity of 92% and a decent specificity for detecting bone metastasis. So the main thing to remember about bone metastasis and FDG PET, that FDG PET can detect a lot of occult bone metastasis, and even in relatively early stage tumors, and it actually can change management. So this was a T2 tumor, but you can see, as you can see here, so there are these two marrow metastases. Here actually, if you see the CT also, you can see there is a marrow deposit. But the main thing is that when you, so this kind of lesions will be detected with MRI also, I assume. But when you are doing MRI, you will not do a whole body MRI. That is very difficult to do. So, but FDG with a single whole body imaging, it can detect this kind of occult metastasis very nicely. So pleural metastasis also, FDG has decent sensitivity and specificity. And even for pleural effusion also, the effusion itself may show increased FDG uptake. And few studies have also shown that that also has good sensitivity and positive predictive value in detecting malignant pleural effusions. So here also, so it sometimes in CT, if there is a mild pleural thickening, it may be a bit dicey whether to call it disease or it can be some benign or past fibrosis. But with FDG, many of those things may be solved. So here this is the NCCT PET. So this lung mass, and you can see there is pleural thickening metabolically active. This is the clear-cut obvious diffuse pleural thickening, FDG habit mass surrounding consolidatory area that is not showing uptake, and big pleural effusion. So now brain metastasis. Due to high physiological uptake, FDG is obviously not very sensitive in detecting brain metastasis. MRI is the investigation of choice. However, dedicated separate brain CT, if it is done during the FDG PET CT, we can detect a lot of metastasis, and in asymptomatic patient, the need for MRI may be obviated. So like this patient, so you can see there is barely any FDG uptake, but you can see enhancing lesion in enhancing solid lesion in CT. So in our department, we now take a separate brain along with MRI, and also TMH, they have now made it a protocol. They do MRI only when either if the patient is symptomatic for the brain metastasis or FDG PET is negative. Because with just asymptomatic brain metastasis, they will not give the patient brain-directed treatment. Restaging PET CT is the best imaging technique for detection of recurrences and can differentiate recurrent disease and pretreatment changes efficiently. And if you are doing a FDG PET after the patient has received some kind of treatment, especially radical intent concurrent chemoradiation, then you should do it after 12 weeks to decrease the amount of inflammation that may be present. So here one example. So here you can see left hilar mass. So post the consolidatory collapsed area, and post treatment, it has completely gone. So, but on the other hand, this left side, there is a mass, and post radical CTRT, but it is still persisting, metabolically active disease still persisting. In this kind of cases, PET really helps. So now we'll go through quickly some pitfalls and some ancillary findings that we see in PET scan that may sometimes confuse and confound us. So this is you can see uptake here, but this is actually liver metastasis, but due to misregistration, you can see the uptake in lung. And consequently, this uptake, this was a lung nodule, but the uptake is seen in the liver because of the respiratory artifact. So many centers now do respiratory gating to ameliorate these things, but this is easy to understand. So this is a thing that we sometimes see. It is not very common, but we do see it often. So this is, we call it FDG embolus, but we don't know the actual reason for it. But one provisional, one hypothesis is that due to faulty injection technique, the FDG forms some kind of colloid, and that gets stuck into the pulmonary capillary bed, and you will not see anything in CT, but you will see focus of increased FDG uptake. So if you see such a scan in a few scan in packs, you will get confused. But if you have to see the CT, and also you have to understand if the patient has been injected from that side. So if you inquire that, then you can solve it out. So, so as we know that FDG uptake is not very specific. So this is a very fine example. So this was a patient being evaluated for SPN. And so you can see this mass with liquefactive necrosis and surrounding consolidation. It came, so we had initially given it as malignancy, but it came out as organizing inflammation and negative for markers for malignancy. So this is a mediastinoscopy port. So this kind of thing, or like chest tube drain, those kind of things are also seen, that any places of inflammation that can be seen. So this is a very nice thing. So sometimes we see, because Warthin tumors also has association with smoking. So it has association with CA lung. So many times you will see that very nice enhancing, well-defined parotid nodules that will be pretty avid, but this is not to confuse with metastasis. They will be Warthin's tumor more often. So elicit history of smoking in these patients. So this diffusely increased uptake noted throughout the skeletal system. So this was reactive marrow uptake. This patient had anemia. So these kind of things may be seen, but we shouldn't confuse them. And so there are few types of lung cancer that do not show significant FDG uptake. So I have one image here that is a typical carcinoid, may not show FDG uptake. You can see here, you can see diagnose it based on CT only, because this is a endobronchial mass, deep, extremely enhancing without any FDG uptake. So this has to be a typical carcinoid. Another cancer is adenocarcinoma in situ or bronchoalveolar carcinoma, though they are also poorly FDG concentrating. So, but those also have like typical CT features, but they may sometimes be confused with infection or some other causes. So I don't have image of that. So some granulomatous infection. So this was initially thought of as a lung cancer, came out as TB. So here you can see tubercular granuloma in liver and also marrow lesion. So they were masquerading as metastasis. So this kind of pictures you see. So another thing, so this was squamous cell carcinoma. So these nodes were all given positive, but with the biopsy, the nodes came granulomatous inflammation. So these kind of things happen, especially in Indian scenario where TB may coexist with. So take home message is FDG PET scan is recommended for initial evaluation in all stages of NSCLC. Coupled with CCT, it is a one-stop shop investigation. And though FDG PET has overall higher diagnostic accuracy in detecting mediastinal nodal metastasis compared to CT, it is not high enough to solely rely on it. And it does not obviate the need for EBUS, GBNA, or mediastinoscopy. Investigation of choice to look for distant mets, it helps in detecting occult asymptomatic distant metastasis, thus changing management. And investigation of choice for assessing recurrence and treatment response, especially after radiotherapy. Thank you. Any question, I'll be happy to take. So it is a bit difficult because if you don't have access to all the images or raw data, it may be difficult. So you have to contact your radiology or nuclear medicine colleagues like that. So, but if the thing is that now, like misregistration, like when we see, so we are seeing uptake here, but you are seeing the nodule is here. So obviously that uptake should correspond, more likely will correspond to the nodule. Sometimes when we see the scan, before we have sent the patient, we may take another scan if we are having confusion. So there the will be registered. So most often this kind of misregistration happen supradiaphragmatic and subdiaphragmatic region due to respiratory artifacts. So many centers, what they do, they will do a respiratory gating. So with G machines, they have a software. So what they do, so they will take a mid inspiration scan with CT scan, and the PET scan that they take. So PET scan for a particular bed will last for a longer time than a CT scan, right? So they have to corroborate that PET finding. So they will take a mid inspiration CT scan, and they will, the PET scan registration, they will take the mediastinal bed lung bed PET scan, they will take for a longer time. Say other beds are for 39 seconds or 40 seconds. So that lung bed, they may take for 1 minute, 2 minutes. Okay, so, and then they will summarize all the different inspiratory and expiratory cycles uptake, and they will kind of make an average, and that shows less misregistration. So these kind of things are available. Many places they do it. Anything else? Thank you.
Thank you, Dr. Sayak, for explaining the role of nuclear medicine with such illustrative examples. That brings us to the end of our session on lung cancer screening, and now we begin our session on interventional oncology. So first speaker in this session is Dr. Devyani Niyogi, consultant surgeon in Tata Memorial Hospital, Mumbai. She will be giving a virtual talk.
Perfect. All right. A very good morning to everybody. And so we're starting off the session on early stage lung cancer. We'll begin with mediastinal evaluation in early lung cancer. I'm Devyani Niyogi. I'm a thoracic surgeon from the Tata Memorial Hospital in Mumbai. Since we're kickstarting the session with this talk, let's begin with what exactly do we characterize as early lung cancer. So according to the AJCC staging, which is the 8th edition that we're currently using, anything that is T1, T2, or N1, N2 is early lung cancer. That means any tumor which is up to 4 centimeters in size or node negative, at the most Hyler node positive. These are the ones that come under early. So if we've already decided that they're early lung cancer on imaging, why do we need to stage the mediastinum? It is basically to detect the radiologically occult N2 and N3 nodes. Lung cancer staging mainly involves these 3 things. You would have done a tissue diagnosis to arrive at your diagnosis, a PET scan for a whole body staging, and an MRI brain to look for any brain metastasis. After all of this, why stage the mediastinum? So the answer to this question lies in the table on the top left. So first of all, only 15 or 20% of lung cancer actually presents in the early or loco-regional stage. And if you notice the circle numbers on the last column, the survival drops precipitously, almost by half, once the lymph nodes become involved. So the nodal status actually determines the treatment options and the prognosis of the patient. It significantly affects the patient's survival. And despite all kind of staging that we do, 12.5% of the times we are still caught unawares with N2 disease. As you can see the survival curves on the right, the red line is N1 node. The green line, which the survival drops pretty precipitously, is the N2 nodal status involvement. Are there any patients where that much of staging with PET CT and MRI is enough? Can we avoid mediastinal staging? So mediastinal staging in lung cancer is actually a rule. The only exception being peripheral lung tumors, which are in the outer 1/3 of the lung fields, and T1 tumors, that is tumors less than 3 centimeters in size, and node negative at the hilum and mediastinum on the PET scan. So your tumor has to fulfill all these 3 criteria for us to safely say that no invasive mediastinal staging is required in this case. So why is PET CT not enough? All other cancers, we do a PET scan and that's the end of staging. The reason is, as Dr. Nilendu will also clarify in his talk, that PET CT in lung cancer is prone to a lot of both false positives as well as false negatives. So when we analyzed our series at TMH with lymph nodes with SUV uptake of more than 4, which in any cancer would be considered as fairly significant, in lung cancer, the false positive was seen in 18% of the time. That is, in 1 in 5 patients, we risked upstaging the patient if we only depended on the PET scan for the mediastinal nodal status. The reason for that is India is a country which is endemic for TB and for granulomatous disease. So even the nodes which are affected by granulomas or TB can look as hot nodes on a PET scan and may end up upstaging your patient quite significantly. The other end of the spectrum is the false negative, which is due to the shine-through effect of organs in the mediastinum, which all have pretty high uptake on a PET scan. And so you don't end up seeing the hot nodes, which risks to understage your patient, and you end up giving less treatment than you would actually the patient would deserve, which is why we come to invasive mediastinal staging. There are two ways to do it. One is the endobronchial ultrasound with an endosonography through the esophagus, which is called EUSB. And the second is the mediastinoscopy. So the EBUS is a relatively new kid on the block. It's way less invasive than a mediastinoscopy. It's done under conscious sedation. And all the guidelines recommend it as the initial step in invasive mediastinal staging. If it is associated, you have a pathologist on site who gives you a rapid on-site examination. It improves the accuracy of your EBUS and also hastens the results. It is associated with absolutely negligible complications. Mediastinoscopy is the gold standard for invasive mediastinal staging. It's a surgical procedure done under general anesthesia. You could have a standard mediastinoscope where you peer in through the mediastinoscope into the mediastinum, or what is more done today is the video mediastinoscopy, where the image is projected onto a screen. And the false negative rate, being the gold standard, is as low as 2%, although it is associated with a few complications in 6%. We'll come to that subsequently. So these are the ISLC nodal stations. EBUS and mediastinoscopy can pretty much well assess your levels 2 and 4 on both sides, as well as the subcarinal nodal station 7. EBUS, in addition, can also evaluate stations 10 and 11, that is the hilar and the interlobar nodes. The mediastinoscopy, if you push it a little in front of the left main bronchus, can also get you to level 5. But having said all this, for both EBUS and mediastinoscopy, the blind spots still remain stations 5 and 6. When we put the EBUS scope through the esophagus, we can also access stations 8 and 9. So our true blind spots in the mediastinum remain station 5 and station 6. So this is the genesis of EBUS. These were the 3 seminary papers that came up on this as early as 2004. And if you see the authors, be it Yasufuku or Anima, all of these were thoracic surgeons. So basically EBUS, though being an endobronchial procedure, was a thoracic surgeon's brainchild. And the early results itself from these centers were extremely impressive. If you see the sensitivity and the specificity, they almost approach that of the gold standard, that is mediastinoscopy, and this was way back in 2004. But the question remains, are these fantastic results reproducible? As with any sonographic technique, even EBUS is operator dependent. It is associated with a significant learning curve, and single center experiences started reporting false negative rates of as high as 20%, which is a very high price to pay when you think about lung cancer. This was shown in a randomized control trial, which is called the ASTER trial, which pitched the combination of EBUS and mediastinoscopy on one side, as against surgical staging with a mediastinoscopy on the other. And what they found, that the sensitivity of an EBUS combined with a mediastinoscopy was a phenomenal 94%. And it brought down the futile thoracotomy rates from 18% to 7%. So the ASTER trial was actually the background and the basis for the ESTS to come up with their 2014 guideline, which is still the latest version. So even in 2022, we are following the 2014 guideline, which says that if your PET scan shows no mediastinal nodes, then any one of the 2 techniques is enough for you to complete your invasive mediastinal staging. But if the PET scan shows suspicious looking nodes, you start with an EBUS. If the EBUS comes negative, it is mandatory to confirm it with a mediastinoscopy. So let's see the journey that EBUS has traversed from 2004 till today in 2022. The false negative rates in most centers that are performing EBUS have become better and better. They're inching closer to the gold standard, that is mediastinoscopy. The sensitivity and specificity, especially from some of the series that are reported from South Korea, are 88% and 100%, which are actually better than mediastinoscopy. And they're associated with almost no complications. So it's becoming more and more attractive. One paper that came out recently that we should know about is the SCORE study, which said that a systematic nodal sampling, where you diligently go into each station, check the nodes, and any node more than 5 mm gets sampled, actually gives better results than a selective strategy where you only target the PET positive nodes. So in today's day and age, is a confirmatory mediastinoscopy mandatory? Why not? because all the studies that have studied this showed that the limited additional nodal met that was picked up with a mediastinoscopy was actually not that significant. The morbidity was something to think about. Not to mention the treatment cost and the delay because you're doing 2 procedures only to stage the mediastinum. And the micrometastatic N2, which were additionally picked up by the mediastinoscopy, had a questionable impact on survival. So Bosima is a big name in mediastinal staging. He did a meta-analysis which said that the unforeseen N2 rate was around 9%, whether or not you confirmed your negative EBUS with a mediastinoscopy. Moreover, mediastinoscopy has a 6% morbidity, including recurrent palsies and chyle leaks. And this unforeseen N2 in this 9%, when they followed it up over time, actually had no impact on survival. So you have the MEDIAST trial, which is currently ongoing. It is just about completing accrual, which will help us answer this question with some evidence backing. Can we forego a mediastinoscopy after negative EBUS? But a mediastinoscopy or a VAMLA, that is a video-assisted mediastinoscopic lymphadenectomy, is not completely obsolete. What it helps the surgeon do is it helps them assess the resectability of the nodes. It gives you a very good clearance for left-sided tumors because the arch aorta comes in the way when you try to clear left-sided nodes by a WATS or a thoracotomy approach. The morbidity is acceptable. It's a palsy rate of 2.4% that we're looking at. And the most attractive thing is the surgeon is enough. So we don't have to depend on anybody else or any other procedure to stage the mediastinum. It can be timed at the same time as the resection of the primary if your institution has a frozen section available. So we've seen what is perfect. We've seen the guideline. Negative EBUS needs to go for a mediastinoscopy. But how perfect is perfect? So we saw in the ASTER trial that a combination of the two gives us a sensitivity of 94%. But we still got it wrong in 9.6% after doing all this. 7% still underwent futile thoracotomies. People ended up paying more just to stage their mediastinum. They ended up waiting more for their final curative intent surgery. And to be honest, with how many centers in India have an infrastructure that can give you EBUS and mediastinoscopy just at the drop of a hat? Next question, how feasible is perfect? So forget India, let's look at Denmark. Okay, and look at this paper which tried to look at the adherence to these protocols in Denmark. The names that I've circled, again, Mr. Bosima makes an arrival here along with Anima, the biggest names in invasive mediastinal staging. And even in their center, this protocol, this strict mediastinal staging protocol was adhered to only in 19% of the patients. EBUS EUS was in initial staging in 43%. And confirmatory mediastinoscopy was done only in 44%, less than 50%. And this is in Denmark, where all healthcare is paid for, all the facilities are available. How can we reproduce this in a country like India? So like with everything else, we need to do a very good balancing act over here. So the way we prefer to do it is pick EBUS when you think that the chance of your node coming positive is high. So you do a less invasive procedure, go in, prove your nodes positive, and send your patient for systemic therapy. But when on the PET scan, you feel that the chances of the nodes coming positive are low, it's best to go in and do a mediastinoscopy, send the nodes for frozen, they come negative, proceed with surgery. So this is the balance that we can find between the two procedures. I'd like to conclude my talk by saying nodal status significantly impacts treatment options. There's no doubt about that. It also helps you to prognosticate your patient. So it is something that needs to be done diligently. What you see is not always what you get on the PET scan. So we know that invasive staging is a must. There is no getting around that. It is difficult to be perfect, but in such a scenario, it's best that we be wise and we choose between EBUS and mediastinoscopy, which works best for us and the patient as well. Thank you very much. I'd be happy to take any questions.
The excellent talk. Kunal sir is still on the way, stuck in traffic. So we continue with the next session of our treatment in lung cancer. With the first talk in this session will be by Dr. Sabita Jivnani ma'am, Associate Professor of Surgical Oncology, Tata Memorial Hospital.
Just one question. You all will be moving the slides or I can move them from here? We can move them? Okay, good afternoon, everyone. I'll be talking about surgery for lung cancer. And these are the topics that I'm going to cover. So we all know lung cancer is a big problem across the world as well as in India. And the stage at presentation, very few present even in the Western world in early stages. So the treatment for early non-small cell lung cancer is typically been surgery. There is no randomized evidence which has so far shown superiority of any other modality over surgery. Although there are upcoming emerging alternatives and they still have to establish themselves. So a little bit to look at the numbers. We register 2,400 lung cancers per year at TMH, and we end up operating approximately 200, which is a measly 8%. And we all know that the survival with curative resection in stage 1 can be as high as 90%. So surgery definitely has a role. And in early stage lung cancer, these patients do really well. Since 1993, when Graham and Singer first reported a pneumonectomy for a lung cancer, surgery has come a really long way. There is now establishment of specialized thoracic units which understand the various biology, the mechanism, and believe in multidisciplinary management of this disease. They have extended the indications for surgery and also understood the importance of lymph node involvement. VATS has made a big dent in the era of minimally invasive surgery, though it was slower to pick up than minimally invasive surgery in the abdomen, for instance. VATS is now more popular than laparoscopic surgery across the Western world. So we should always know when not to operate, when we have extensive disease, when we have distant metastasis, when we have contralateral, mediastinal, or supraclavicular lymph nodes. And also when our patient is unlikely to withstand surgery, when they have emphysema, they have morbid, comorbid conditions, where the act of surgery as well as the post-operative outcomes are not going to be that great for that patient, and they will end up with a life which is worse than they had with the disease. So we need to assess fitness before we embark on surgery. Typically in the OPD, you would ask a patient about their performance status, how many flights they can climb. And then we also make them undergo a pulmonary function test, calculated the predicted post-op FEV1 and DLCO, and also do a 2D echo. Pulmonary artery pressure measurement is required when the patient is undergoing a pneumonectomy, and 6-minute walk test is mostly done by all units. We need more advanced testing when the patients are borderline fit or they are going to undergo a very major resection. So the things that come to mind are a lung perfusion scan, which can actually tell you how much of your functioning lung is contributing to the pulmonary function test, a dobutamine mean stress echo if a patient has a cardiac comorbidity, and the gold standard remains the CPET or the cardiopulmonary exercise testing, where a EKG stress test is combined with a metabolic gas exchange analysis, and it gives you a value of VO2 max, which tells you whether your patient is going to be able to withstand the stress of surgery. So surgery for early non-small cell lung cancer typically involves invasive staging of the mediastinum, which has already been covered by the previous speaker. And I will only be talking about the surgery for the primary and how we address the lymph nodes. So the extent of surgery was well established in the 1990s when there was this seminal paper by Ginsberg's group, where they did limited resections in T1N0 and compared them to a lobectomy. These were patients who had tumors less than 3 centimeters, because in 1995, by that classification, T1 was less than 3 centimeters. So what they saw was that there was a 75% increase in recurrence, 30% increase in overall deaths, and 50% increased cancer deaths. But we have to remember at that time, there was no PET-CT as an established role for lung cancer staging. But this trial, however, established lobectomy as the gold standard for surgery for lung cancer. And as recent as this year, we have seen that segmentectomy does not fare far too worse. So in this paper by Asamura, which has also been called the trial of the decade, patients who had tumors less than 2 centimeters were randomized to get either a lobectomy or segmentectomy, and those undergoing segmentectomy actually had a better survival. They actually this was a non-inferiority trial, but they ended up showing superiority. They expected the lung functions to also be very much different and better with segmentectomy, but that was unfortunately not the case. So what does a pneumonectomy entail? A pneumonectomy entails removing of the entire lung on the ipsilateral side. And now pneumonectomy is actually recognized as a disease. It is very morbid. The morbidity will be in one out of two patients undergoing a pneumonectomy will have some or the other morbidity. The mortality in experienced centers is as high as 10%. And there are several post-operative functional implications because the entire cardiac volume starts going through one pulmonary circulation, and this causes the pulmonary artery pressure to go high and can also result in right heart failure. There can be cardiac torsion, the shift of the mediastinum, and many other complications that don't allow the patient to have a good quality of life after this surgery, even if they are cancer-free. But it is sometimes a necessary evil, and we may not be able to get away from it. So when the major hilar structures are involved, pneumonectomy, when it is R0 resection is possible, may sometimes be necessary. Extended resections have come into vogue in the last 3 years, where surgeons have been exploring removing the vertebrae, removing the vessels such as the superior vena cava, along with the lung primary. And this has shown reasonable outcomes, especially when the mediastinal nodes are not involved. We have to remember that T4 and N3 are different diseases with a different biology. And in selected T4 N0 patients, we really can achieve some good outcomes. So you have to adhere to the selection criteria. Make sure that you're going to be able to get a R0 resection. Your patient is fit to withstand extensive surgery. And obviously, the mediastinal nodes are not involved. Pancoast tumors is one area where trimodality has been established as the standard of care. Lobectomy, along with the primary and the chest wall, is preferred compared to a wedge resection. Most of the recurrence patterns are local, but complete resection is crucial. Sleeve resections, in the last 10 decades, we have seen more and more of sleeve resections, especially now being done minimally invasive also. It's a parenchymal preserving surgery, and although it was initially started as surgery for patients who are not fit to get the entire lobe or the entire lung out, now even in fit patients, it is becoming the norm and the standard of care as long as you can get negative margins. Negative mediastinal nodes, even in this group, carry the best prognosis. There are a number of papers over the last 2 decades which have shown that the 30-day mortality with a sleeve resection is lower than that with a pneumonectomy. Also, the complications are lower and the 5-year survival is comparable. So coming to surgery for M1 disease or oligometastasis, which is the buzzword since the last 5 years, we have seen numerous abstracts at the World Congress of Lung Cancer as well as ASCO. It is to be remembered that this has to be offered and to be done in highly selected patients who have typically solitary or now extending the indications 3 to 5 metastases. Good survivals have been seen, but most of the data comes from adrenal and brain metastasis. Long-term data from other sites of metastasis is still yet to mature. We also offer surgery when patients have bilateral primaries. In the era of screening, when you pick up multiple ground glass opacities, in limited stage small cell lung cancer, and in carcinoids. So once you've taken out the primary, your surgery is not complete. You still need to do a good lymphadenectomy. And the initial large randomized control trial which addressed this was the ACOSOG Z0031 trial of 1,000 patients. And this was expected to show a superiority of systematic mediastinal lymph node dissection over mediastinal sampling. But what happened was that even in the sampling arm, the sampling was so thorough that it ended up showing no difference in oncological outcomes and only showing that the operative morbidity was not higher. But finally, when the meta-analysis by Mokels et al. Came out, it showed that systematic mediastinal lymph node dissection is better for survival. And now most guidelines recommend that we do SMLND. So surgical approach, these pictures actually show that, the minimally invasive approach is a no-brainer. It is associated with better post-operative outcomes, less pain, but it has never shown a superiority in oncological safety or shown better outcomes in terms of survival. So it is just another approach. You have to remember the basic principles of surgery remain the same, whether it's open or VATS or robotic. You have to get an R0, you have to do a lymphadenectomy, and you have to try to minimize complications. So video-assisted thoracoscopic surgery, like I said at the beginning of my talk, came into being in the 1990s And now most of the units have at least 50% of their work being done minimally invasive. Multiportal VATS is now giving way to uniportal VATS, and numerous studies and meta-analysis have shown less post-operative pain, early recovery, less hospital stay, improved quality of life, at least equivalent oncological outcomes. And now we have randomized evidence. This was published early in 2022, where surgery through VATS was not only associated with less pain, but also fewer in-hospital complications, leading to a shorter length of stay. But we have to remember that the air leaks were far more in the VATS arm. So at 1 year, when they evaluated the physical function of the patient, it was far more superior compared to the open approach, but long-term oncological data are awaited from this trial. Robotic lung resection is no longer the new kid on the block, has been around for more than 10 years. Dr. Sarfolio has already reported 2,000 cases, and there are several series with more than 500 patients which have reported comparable short-term outcomes as compared to VATS. It also has purported to have a shorter learning curve compared to multiportal VATS and a larger lymph node yield. So the robotic surgeons say maybe it is more radical surgery, but we have no oncological outcomes yet. And cost is the biggest barrier to its uptake. So to summarize, lobectomy is still the gold standard. Segmentectomy, which is less than a lobe, and extended procedures are justified only in selected patients and high volume centers. Minimally invasive approaches offer better short-term outcomes, and systematic mediastinal lymphadenectomy has to be performed in all patients. So post-operative management needs to be aggressive with early mobilization and picking up your complications soon enough. And there are established indications for adjuvant therapy, which I'm sure will be covered by other talks too. So this is just an algorithm which is available in our evidence-based management guidelines, how we manage patients with early stage lung cancer and those with mediastinal lymph nodes. And with that, I'll say thanks, and I'll be happy to take any questions. Thank you.
Thank you, ma'am, for telling us the various types of surgeries that we can conduct for lung cancer. Our next talk will be on radiotherapy in lung cancer by Dr. Naveen, Associate Professor in Radiation Oncology at Tata Memorial Hospital.
Should I open it? A very good afternoon to everyone. I'm here to talk about radiotherapy in lung cancer. Where are we? In the next 10 minutes, I'll try to do justice to the topic. This is the outline. I'm going to talk about the role of radiation in early stage, locally advanced, and also a bit about RT and oligometastatic disease. This is the management overview, although this is a crowded slide. What I want to impress upon you is that radiation plays a pivotal role, not just in early stage, not just in stage 1, stage 2, but also in stage 3 and stage 4. So there is a role of RT everywhere in each stage of lung cancer. In early stage lung cancer, we heard from the previous speaker that surgery is the standard of care. However, there are risk groups within that subset of set of patients. You have low risk surgical patients who can be treated with the standard of care, but you also have high risk patients who might end up having a sublobar resection, or they might have an option of getting stereotactic body radiation. And then you have the frank medically inoperable patients where SBRT is the standard. So SBRT or stereotactic body radiation therapy is not something which is very new. It was reported as early as in the mid-90s, where clinical evidence showed its efficacy. But in lung cancer, we started seeing phase 1, phase 2 studies in the early 2000s. And since then, there has been a deluge of institutional and multi-institutional literature on SBRT. So initially, we had stereotactic body radiation, the role of it in medically inoperable patients, retrospective series which showed excellent local control of 85 to 90%. And also we had subsequently certain prospective series, although the numbers weren't so great, but the local control rates are very much comparable to the retrospective series. So this kind of established SBRT as the only treatment option that is possible in medically inoperable patients. But in operable lung cancer, it has always been a sore point, because as you heard from the previous speaker, surgeons are keen to operate on stage 1, stage 2 lung cancer, even if they don't have adequate lung function, because of certain inherent advantages that surgery provides in terms of histopathological analysis of the primary and the nodal disease, which gives you an opportunity to tailor your adjuvant therapy. The advantage with stereotactic body radiation being that it is non-invasive and the local control rates are as good as surgery is what our contention were. But we do not have any a very robust data on this because there are very limited randomized controlled trials. And also when you compare surgery, you have a subset of patients who might turn node positive and receive adjuvant therapy. So it's not actually comparing apples to apples. And also post-radiation, there is always a challenge in comparing whether the patient has a true recurrence or if this is post-treatment changes. So short of a level 1 phase 3 randomized controlled trial, what we had the closest are certain propensity match score analysis where you have similar patients compared, although not in a randomized fashion. And there are many of these. And what they have shown over all these different 10 papers is that it is either SBRT and surgery are superior, are similar, and certain studies which say that surgery is better and certain studies show that SBRT is better. So the search for the gold standard in operable stage 1 lung cancer continues. There were a couple of ambitious randomized trials which tried to address this issue. However, they were unable to accrue patients. The STARS and the ROSEL study across the Atlantic, they could not combine, they could only accrue 56 patients. So the STARS group in North America, they tried to expand their protocol and they included 80 more patients in a prospective randomized prospective fashion. And then they compared with a similar subset of surgical patients, and they showed that probably surgery and SBRT are equivalent in terms of both short-term and long-term outcomes. So there are various ongoing trials, which probably in the next 4-5 years would give us some idea as to if there is really a clear winner in this scenario. However, SBRT is not without its problems. They early in the 2000s, we knew that patients who had the disease very close to the central airway, if you are little overzealous and treat them with high dose of radiation, you might end up having a lot of toxicity. So we kind of established this no-fly zone around the airway, where we felt that if the lesions are close to this, it is better to avoid giving radiation to these sites. However, over a period of time, we realized that it is not the location, but the dose that we need to tailor. And now with a risk-adapted strategy, we kind of divide these locations into central, ultracentral, and peripheral lesions, where in peripheral lesions, you can give a higher dose per fraction, while in central and ultracentral, you need to be a little more conservative with your treatment. However, the challenge in early stage patients who receive SBRT is that many of these patients eventually develop local, regional, and distant metastasis, making it very essential that these patients receive some form of adjuvant systemic therapy. There has been a lot of interest about adjuvant chemotherapy in these patients, although there is not much randomized data on this. We know that SBRT is also an immunomodulator in it, that it increases the immunogenicity and the antigenicity of the tumor, thereby acting as an in situ vaccine. So SBRT and immunotherapy is a very novel and attractive combination, and there are a lot of trials again which are ongoing, which over the next decade or so we will know which is the best combination, whether in the neoadjuvant setting or should they be given concurrently or should they be given in an adjuvant setting. Coming to stage 3 lung cancer, there are two major subclasses here, resectable and the unresectable ones, and radiation has a role to play in both these subset of patients. In resectable patients, although the standard of care is to do surgery followed by adjuvant therapy, or in some patients giving neoadjuvant chemotherapy or immunotherapy followed by surgery, there is also some interest in giving neoadjuvant chemo-RT because some studies showed that there is better mediastinal downstaging with giving radiation and chemotherapy in the neoadjuvant setting. However, this does not always convert to a survival benefit, and also it adds to the toxicity. So this is not really taken up as well. In resectable patients, the question is also whether should you consider these patients for surgery or should these patients undergo a definitive CTRT. There were two major trials, one of the intergroup 013 and Albine's paper, which kind of showed us that compared to surgery and definitive CTRT, probably the survival is similar. But when you look at a subset of patients who undergo lobectomy, they definitely is an advantage of these surgical cohort over the definitive radiation patients. So in resectable patients, we have an option of doing surgery followed by adjuvant chemotherapy. in patients who have T3, T4 or N0, N1 disease. And in slightly advanced disease patients, you do neoadjuvant treatment where chemo-RT can be an option, but not universally practiced. In unresectable NSCLC, we have gone through a lot of evolution over the past 4-5 decades, starting with the earliest paper in 1980, where radiation alone was used in a subset of patients who were not able to undergo surgery. And there, this seminal paper by Perez kind of established 60 gray as the standard when they compared 40 versus 50 versus 60 gray. Since then, there are many other host of studies which have established that compared to radiation alone, giving chemotherapy and radiation in combination improves survival. And similarly, giving sequential chemotherapy is probably inferior to giving concurrent chemo-RT in select patients. Then we kind of reached a place where we thought of escalating the doses. Although 60 gray was established in 1980s, 4 decades ago, we thought whether by increasing the dose, we would be able to improve outcomes. And unfortunately, this paper, the RTOG 617 Bradley group, showed that giving a higher dose actually worsened the outcomes. So what we learned in unresectable NSCLC is that CTRT is a standard of care. However, it is associated with slightly higher toxicity. And not all patients are actually candidate for CTRT. There are still a group of patients who would not be able to tolerate, especially the ones who have a large volume disease or elderly patients who would not be candidates for multimodality treatment, or patients with inadequate pulmonary function tests. In these patients, probably sequential CTRT is as close to the best treatment that is possible. And when you're doing CTRT, it is always better that you do a higher conformal image-guided treatment, because it can definitely reduce the cardiopulmonary toxicity. And we also learned that conventional way of escalating the doses is not actually associated with better control. So we have now looked at ways of doing unconventional dose escalation, and these are the various ways in which this could be obtained. The first and the most interesting of this is something called as an isotoxic dose escalation, wherein you kind of keep your normal tissue dose constraint at a pre-specified level, and you try to increase the dose to the target as much as possible till that threshold is reached. And many phase 1, phase 2 studies have evaluated this paradigm, and they've showed that it is safe and possibly associated with better outcomes. There's an ongoing phase 2, phase 3 study which would probably establish the value and role of this form of dose escalation. Also, PET-based boost, where conventionally we give a dose escalation to the entire tumor volume. Instead of doing that, if we can do a mid-treatment PET CT scan and boost only the dose to the volume which is remaining after a specific amount of radiation, that has been associated with better local control and no increase in toxicity. We can also do stereotactic boost instead of doing the conventional way, and many studies have shown the feasibility and safety of doing this. And now we have proton therapy as the next big thing in radiation oncology, along with the other forms of hadron therapy. And many retrospective and some prospective studies have shown that it definitely improves the toxicity, and we don't know how much it would add on to the survival outcomes, although ongoing phase 3 randomized control trial is expected to answer the question. The other paradigm that we are exploring currently is doing something called as a functional lung sparing, wherein we can functionally evaluate the lung and then subsequently spare the part of lung which is actually working physiologically well, as opposed to a physiologically non-functional lung. Immunotherapy and radiation, we'll keep hearing about it. Whether it is really a match made in heaven or are we just in the honeymoon period, we really don't know. But we know that as of now, radiation-induced in situ vaccination kind of improves outcomes. And especially in unresectable NSCLC, the Pacific study has shown with its tremendous improvement in survival outcomes. We know that this is kind of established that as the standard of care. However, there are a lot of ongoing trials, not just in the adjuvant setting, but also in the neoadjuvant and concurrent along with radiation giving immunotherapy. We might have more ways to address the problem than in one. Also, we are looking at biomarkers, wherein although we have been currently treating all patients with CTRT, there may be a way of selecting certain patients by usage of the circulating free DNA and the circulating tumor DNA, and also by measuring the MRD, you could actually tailor their adjuvant therapy accordingly. This is one of my favorite slides because it shows that how we have actually evolved with our treatment over the past 4 or 5 decades. We started with the median overall survival of 10 months way back in 1980, and we now reached almost 50 months with the addition of concurrent radiation and chemotherapy along with adjuvant immunotherapy. Coming to the last segment, a bit about oligometastatic disease. There are various terms that are being used, oligoprogression, oligopersistent, oligometastasis. And there is a rationale of using local radiation in these patients because many of these patients predominantly fail locally. And by giving radiation to this local disease, we could probably check their growth of that local disease and prevent organ dysfunction and death subsequently. There are many phase 2 studies. These are 2 seminal papers by Punita Iyengar and Daniel Gomes, which was published in the last 4 or 5 years, which established the role of local RT in a phase 2 manner. The Saber Comet was the first phase 3 study, which again showed in a different group of patients, not just lung cancer, limited to lung cancer, that giving local RT in addition to systemic therapy improves overall survival and not just progression-free survival. However, we need to wait for phase 3 randomized controlled data before we start using this for every patient. And until then, we'll have to choose wisely our patients and the modality of treatment that we use. Some of the ways that we could actually choose these patients are by looking at their clinico-radiological profile, which might give us an inkling about their biological behavior. To summarize, the past of early stage and locally advanced and oligometastatic radiation, although radiation has been part of that treatment paradigm, we have expanded a bit in the present by the addition of multimodality treatment, where we have added chemotherapy, immunotherapy, and a combination of surgery in some patients. And the future looks bright with the increasing availability of different immunotherapy molecules. I'll leave you with this slide, and I'm happy to take any questions if they're there.
Thank you, sir, for explaining the different options that are available for radiotherapy in lung cancer. Next talk will be by Dr. Kunal Gala, sir, Associate Professor of Interventional Radiology in Tata Memorial Center.
So very good afternoon to everyone who is attending the conference online and offline as well. Okay, so the topic for today is image-guided tissue sampling. So the role of tissue sampling is most important before starting any treatment. So one is to prove the malignancy, second is to guide the staging, third is the treatment planning. So the tissue sampling is the most important thing. So there are different types of biopsies which are available. It could be surgical biopsy, it could be endobronchial biopsy with the help of bronchoscopy or EBUS guided biopsy. And a third, which the radiologists are interested is percutaneous biopsy. Percutaneous biopsies could be in the form of either ultrasound guided percutaneous biopsy or CT guided biopsy, that I will be coming to the later. And why image guided biopsy is most important. One, it is more precise as compared to just open biopsy. We can technically target the metabolically active area, which is there, as we can see in this diagram, that the medial component is metabolically active and we can target this area accurately. There is less incidence of repeated sampling, and it is safe because it is directly under the vision. So whenever there's any vessel or any bronchus which is coming in the path, we can avoid it by going either superior or inferior or medial or lateral. And coming on to different imaging modalities, one first is ultrasound guided biopsy. This is a conventional ultrasound. If there's a neck node, obviously we can target that much better. Pleural thickening can be targeted with the ultrasound procedure. Whenever it is a mediastinal lymph nodes, it is done generally for staging. Then we can target either with FNAC or FNAB. Depends on case to case basis. Third is a fluoroscopy guided biopsy. This is basically to prove metastasis whenever it is there. So when you are doing complex intervention or biopsies in the spine, and it is much better to do it under fluoroscopy because it is real time with combination of CT scan. So another is to confirm the primary diagnosis in case of lung cancer. Under CT scan or a CT fluoroscopy guided, and another is combination therapy with the help of PET CT scan. So the fusion imaging helps where the area is metabolically active. So image guided, the significance is there is high accuracy, there is high sensitivity, high specificity, and in image guided biopsy, the sensitivity is around 82 to 99%, and specificity is 86 to 100%, and accuracy ranges from 64 to 97%. So this is for the malignant lesions. Coming on to the indication of biopsy, why we need to do biopsy. So whenever there is a new lesion, when there is enlarged solitary nodule or a mass which is there, when there are multiple nodules and you can't, so when the patient comes with multiple nodule, to characterize those lesions in case of hilar masses and in case of focal infiltrates. So in case of focal infiltrates, either it could be malignant or benign. Okay, but TB being most common, we need to send for culture and sensitivity as well. Whereas in lung cancer, in the era of personalized therapy, the biopsy is most important, where you can study the molecule on those and give a targeted based therapy to the patient, and where the side effects is much lesser. To classify to histopathologically subclassification of these tumor and for the molecular markers. So a contraindication for any image guided biopsy or in image guided tissue is that when the patient is uncooperative, unresponsive, obviously it is very difficult to perform those kind of biopsy. However, can be performed under general anesthesia. When there is positive pressure ventilation, that is the time it is difficult to do biopsy because the pressure inside the lung increases. When there is severe respiratory distress, obviously he can't hold the breath, he can't follow the instructions. So that's why respiratory distress is another thing. Pulmonary hypertension is another thing where there would be bleeding of bleeding can happen profusely, and interstitial lung disease. However, those are most of them are relative contraindication. Coming on to the needle biopsy pre-procedure evaluation. So before starting any biopsy, one need to check the guidelines and check the prerequisite, what is required. So the most important is CBC platelets, and platelets above 50,000, coagulation of INR of less than 1.5, 1.5 is required. If patient is on any antiplatelets or anticoagulants, that needs to be stopped. And obviously patient need to be informed about the procedure and the complication associated with it. The most common complication is a pneumothorax, and needs to be counseled regarding a pigtail drainage. If patient is flying abroad, flying to out of station or his hometown, patient needs to be counseled that after a lung biopsy, you can't fly out because there would be increase in the barrow pressure, and then the pneumothorax can increase or worsen. So does every lesion require a biopsy or a tissue sampling? So we need to have a CT scan with a contrast for all patients before doing any biopsy. So this was an interesting case which came to Tata Memorial Hospital, and this was a mass which was reported, and obviously right. However, there was no contrast which was available, and after doing contrast, what we found was a pseudoaneurysm which was arising from internal mammary artery after after doing a contrast scan. So we need to be careful, and always a CT scan with a contrast is advised. And this was an angiogram which was done, and after going super selectively into the internal mammary artery and coiling that vessel, and thus the bleeding, the patient was not having any mass. So the image guided procedure, the patient positioning is also equally important. So location of the lesion, if the lesion is located posteriorly, as in this case, it is easy to target via prone approach. If the lesion is located in and the anterior aspect, then the supine approach needs to be done. The size of the lesion is also important. Why it is important? Because the smaller the nodule, the chances of it missing is much more there. Another thing, the chances of pneumothorax increases. There is increase in the hemorrhage around the lesion, which can happen, and then ultimately the lesion can disappear. So this can happen once in a while if you're doing it occasionally. Patient position can be either supine, prone, lateral, decubitus. It depends upon the patient's comfort as well as the operator's comfort. And prone is generally preferred because one patient can't see the needle and the anxiety of that patient becomes lesser. The posterior ribs move less than the anterior ribs, and it decreases the anxiety. So targeting the lesion, always and always the peripheral wall, a solid area needs to be targeted, as you can see here, or a central hilar mask needs to be targeted, or a solid enhancing area needs to be targeted. And this was easily targeted, and where we need a PET CT scan. So this is a central hilar lesions which is there. We can go either via the collapsed lung or posteriorly, as we have gone here, and then we can do the biopsy and target those easily. So as in similarly, if there is a bulla or a cyst which is there, and there is a PET avid lesion which needs to be targeted. So for some of the basic concepts and anatomy, and it is for a CT guided procedure, and that one needs to be take care about the internal mammary vessels which are located on either side of the sternum. Another is a fissures and a pleura, and a third is a rib. So always remember, when we are penetrating, the intercostal vessels and nerves are located inferior to the rib. So always go superior to the rib or in the intercostal space. And internal mammary vessels, especially for mediastinal lymph node biopsy, either we can do hydrodissection, we can palpate the sternum and then go into the nodule. So this is how we need to approach, rather than from the posterior aspect. So another is a fissures. Always beware about the fissures. Two fissures on the right side and one fissure on the left side, and this needs to be avoided as far as possible. But many times we can't avoid it. So virtually, if we penetrate the fissure, then we will be piercing at least 4 pleuras. So the parietal visceral of the outer surface and parietal viscera of the inner surface. So we will be penetrating 4 pleuras, and the chances of pneumothorax increases significantly. So that's why generally when we tell you go from either do a hydrodissection or avoid those things. So fissures are important, as seen here. So this is the wrong approach, because we have penetrated the fissure, and this is the right approach where we need to avoid it. While doing a CT guided biopsy or tissue sampling, the scan has to be in low kV MA, limited slices. Local anesthesia needs to be given generously. Coaxial technique is always preferable over a single puncture needle, because you can take multiple course from that, and the needle length needs to be decided priorly. Either you can take a longer needle or a shorter needle. If there are more bullets, then the smaller gauge needle is preferable. So coming on to the post biopsy care, post biopsy care checks CT scan imaging needs to be done either X-ray or a CT scan. Post biopsy generally recommendation by BGR guidelines is do X-ray chest at 4 hours and then observe it. If it increases more than 20%, then either a small bore catheter needs to be inserted, or and there are few cases where there could be delayed complications. So another thing which comes for tissue sampling is endobronchial ultrasound. So this is the technique where the scope is inserted via the trachea into the tracheobronchial tree, and it is done for the lymph nodes around the mediastinum and for the primary mass. So this is how the scope looks like, and this is how the needle enters, and the biopsy or FNAC is taken from the representative area. So coming on to the few indications of EBUS is for staging of mediastinum, where non-small cell lung cancer is suspected, sampling of the mediastinal lymph nodes, diagnosis of unexplained mediastinal lymphadenopathy, and as a research tool for tissue banking and studies for later on. So what are suspicious lymph nodes on endobronchial ultrasound? One, the classical characteristics like a round shape, a loss of fatty hilum, a heterogeneous echo texture, a presence of necrosis, and more vessels at the hilum. So, and what's the advantage? So it is a minimally invasive technique. It is a real time, as we are doing it under ultrasound guidance, and which has a high diagnostic yield. It is a safe procedure. It can be done under local anesthesia with mild conscious sedation. And EBUS can target wide range of lymph nodes, right from hilar, 2R, 2L, 3P, 4R, 4L, and so on and so forth, and centrally located pulmonary lesions as well. So dual benefit, you're doing a staging as well as doing a sampling at the same time. Decrease in, the advantage is it decreases unnecessary thoracotomies and complication. So a limitation, obviously, as ultrasound, it is operator dependent, cannot target subaortic or prevascular lymph node because they are situated anteriorly, anterior to the vessels, and a lack of availability at all places. And the cores are inferior as compared to the percutaneous biopsy. And it is an aerosol generating procedure. So during the COVID times, you can't do the procedure. But just a few of the examples which I would be seeing here. So in all these are four different cases, all of small cell lung cancer, and what we can see here, the lymph node located around the vessels. Here also it's a similar thing. So paratracheal lymph node or pretracheal lymph nodes. All throughout at 270 degrees, it is located in vicinity of vessel. The percutaneous approach is not possible in all these cases. So what we can do is, since it is located close to bronchus or a trachea, we can do it with EBUS guided procedures or FNACs or a biopsy. So coming on to the last slide and a take-home message, a minimally invasive procedure. So percutaneous biopsies or tissue sampling, it is a minimally invasive procedure. It is very safe and effective in with good accuracy. It is a daycare procedure and can be performed by experienced physician. Thank you. If you have any queries, you can email me or I can answer it. Yeah. So as in today's era, so with the help of with the advent of more and more tissues being required for molecular analysis, percutaneous guided biopsy is much more preferable because the amount of core that you get is highly you can get more amount of cores compared to an EBUS technique. So EBUS, either you can get a small core and it is less than 20 gauge needle. With percutaneous, you can go up to 18 or 16 gauge needle, and the quality of core is much better with the percutaneous procedure. No, if you see the chances of pneumothorax is almost like less than 20%, and out of which the drainage required is around 5 to 10%. So almost 50% of the, so 80% of the patient don't cause any pneumothorax. Even if they cause, they are so negligible that it resolves on its own. It seems like a balloon, and then you are piercing the balloon, but it does not happen anything. Okay, thank you.
Thank you, sir, for explaining the role of interventional radiology in the diagnosis of lung cancer. Now, the next speaker is Dr. Falguni, interventional radiologist at Tata Memorial Center.
So, good afternoon, everyone. So, I am now presenting about hot and cold ablative procedure in interventional treating primary and secondary lung cancer. So the treatment option for primary and secondary lung cancer are the surgery, radiotherapy in the form of like stereotactic radiotherapy, SBRT, chemotherapy, and the ablative procedure. Ablative procedure are like hot and cold ablative procedure and the non-thermal ablation. So common ablative procedure is thermal or non-thermal. Thermal is like heat-based ablation, that is like radiofrequency ablation, laser ablation, HIFU, and the microwave. In lung cancer, that laser ablation and the HIFU is not that popular, but in RFA and microwaves are generally used. And in cold-based ablation, there is cryoablation. Both that liquid nitrogen and the argon, both are used as a cryoablator. And in non-thermal ablation, then IR is the most important procedure. And other ablative procedure like chemical ablation, absolute alcohol and acetic acid, these are not used in lung cancer. It's mostly used in the solid organ ablation. So role of ablation when that patient is not suitable for surgery, like high comorbidity, recurrence after surgery, so that anatomy is get distorted, and the adjunct to the surgery, as that only one lung to be ablated and the other lungs to be operated, and as a palliation procedure like pain palliation, where that patient is not fit for surgery, only to relieve the pain. So ideal candidate for ablation is the like primary cancer, only non-small cell carcinoma in stage 1A that can be operated, that can not be operated, but that is due to that is like poor cardiorespiratory comorbidity or insufficient lung vital reserves. But after the operation or lobectomy, there is a changes of the pulmonary function test. But in our study, like ablation causes only transient changes in the pulmonary function test, but not it is a permanent thing. And in metastasis, up to 5 lung nodules can be ablated. That ablation most likely we do in our settings like colorectal carcinoma, metastasis from colorectal carcinoma, soft tissue sarcoma, renal, breast, esophageal, testicular carcinoma, etc. And contraindication for ablation is the like small diagnosis of small cell cancer. Because that small cell cancer usually diagnosed at the later stages, so it usually is in advanced stage, so it is cannot be ablated as a curative procedure. Stage 2 non-small cell carcinoma, it cannot be ablated as a curative option, but palliation as a pain palliation can be done. And presence of nodal and distant metastasis, so that is not a good candidate for ablation. And uncorrectable coagulopathy, it can be corrected by other measures that can be ablated at that time. And ECOG more than 2 is not a good candidate for ablation. And where life expectancy is more than 1 year, less than 1 year, that is not a preferable candidate. End-stage lung disease or respiratory failure is not a good candidate, but as we already discussed that ablation do not changes the pulmonary function test, it only changes the pulmonary function test transiently. And lesion located to hilum within 1 centimeter, a large vessel, these are relative contraindications. We can do like hydrodissection or artificial pneumothorax just before the ablation. So these are the relative contraindications. So now radiofrequency ablation, it uses alternative current and it AC current. So it generator oscillates between the electrodes through the ion channels, and it causes frictional energy within the tissue. So it generates the heat at the ablated site. So this agitation or frictional energy causes heat generation at the area. So these are the electrodes from the generator, and this is the RF electrode, and these are the grounding pads. Sorry. So grounding pad, and the surface area of the electrode and the surface area of the grounded has surface area long difference. So that causes more agitation at the surrounding the area of the electrode. So it causes maximum energy deposition at the electrode site. So it causes temperature increases, and when temperature increases more than 54 degrees centigrade temperature, it causes instant tissue death. So in our practice, we use more than 60 degrees centigrade temperature and less than 100 degree temperature to ablate the lesion, and it causes ultimately coagulative necrosis. So pre-procedure follow-up workup, we do like total body PET CT or CCT for the staging, mediastinoscopy in some cases like non-small cell carcinoma, and EVAS for the needle aspiration and other blood parameters. Or if any antiplatelet or anticoagulants so we need to discontinue for according to their guideline. And procedure feature we do usually in the under GA or under conscious sedation, and under GA is preferred because we usually do under near the vital structures at that time, and to reduce the pneumothorax, to reduce the respiratory movement, we use small tidal volume. It decreases the chances of pneumothorax at the time of needle placement. And a same principle we follow during the ablation, during the needle placement, just avoid the pushing lung fissure, should avoid the transfer minimal lung parenchyma. But in case of peripheral lung lesions, we used to use the trajectory through the lung parenchyma. And coaxial techniques also reduces the chances of pneumothorax. And microablation, it also causes coagulation necrosis, but it uses electromagnetic wave, and it causes electromagnetic field to electric field. And advantage of the microwave ablation is that faster and more uniform heating, and less dependent on the tissue properties, and less dependent on the thermal conduction of the lesion. And in microwave ablation, no grounding pad is necessary. So these are the, and complication like only pneumothorax is the main complication, but only 10 to 20% cases require drainage. Otherwise, intraprocedure major complication like hemorrhage that can be treated by blood transfusion or angioembolization. And cryoablation actually that it depends, that it based on the Joule-Thomson effect, that changes in the temperature when it passes through the higher pressure to lower pressure, and expansion of the gases causes decrease in the temperature, and it reaches up to the temperature to almost minus 150 degree temperature. In clinical settings, less than 20 degree temperature, minus 20 degree temperature causes cell death. It causes intracellular and extracellular ice crystal formation, and it causes just poration of in the cytoplasmic membrane and causes cell death. So in two types of gas we usually use, one is the argon and another is the nitrogen. So in cryoflow, that gas is passed through the through that aperture is small aperture, then it is expanded in the big aperture and causes sudden expansion of the gases and causes decrease in the temperature. So this is the cryoflow. That tip portion, it usually is the active portion, and near the tip that temperature reaches up to minus 150 degree temperature, and at the surface of the ice ball it usually 0 degree temperature. So to achieve the ablative margin, so we need to ablate the more than 5 to 7 millimeter, and that ice ball can be monitored in the CT and ultrasound or MRI anyway. So this is the death mechanism of the ablation procedure. So intracellular ice and extracellular ice, both are important for cell death. That intracellular ice formation occurs under rapid cooling and at the sites where cells are tightly packed. So intracellular ice compresses and deforms the nuclei and the cytoplasmic component and induces pore formation in the plasma membrane and results in permanent dysfunction of the cell and the transport system. And in the extracellular formation is a moderate freezing temperature and slower cooling rates. So ice crystal sequester the frequent and which increases the solute concentration has the tonicity of the external component. So both causes destabilize the cell membrane and causes the cell poration and ultimately causing the cell swallowing and cell bursting. So during cryoablation, we use two cycles on freezing cycle and thawing cycle. Both are important. So our principle is rapid freezing and slow in thawing. So this is the main important for effective cell death. So in summary, this optimal technique for the destruction of the tumor is the rapid freezing of the tissue and the appropriate low temperature slow thawing. And before the removal of the needle, the passive thawing is most important to decrease the injury. So there is a difference between the cryoablation and the heat-based ablation. That ablation, that RFA or microwave, it causes hypothermia and damage to the cancer cells. And in cryoablation causes ice crystal formation. Real-time imaging is better in clear view in the cryoablation. And in post-ablation boundary is also better, is smooth, uniform is in cryoablation, that is irregular and unpredictable in the RFA. And in RFA, it is causing little more pain, so heavy sedation or general anesthesia is preferred, but cryoablation can be done in light sedation on local anesthesia. And that abscopal effect, that is the immune stimulatory effect, it is more in cryoablation because it causes pore formation in the cell membrane and causes that immune system, that cancer antigen to expose to the cell body's immune surface, immune complex, immune system. So it causes antibody formation against the cancer cells and cancer antigens. So there is better abscopal effect in the cryoablation. That is also seen in the RFA and microwave, but it is better in cryo. And image guidance both can be done like USG, CT and MRI. And treating time is more in cryoablation. But it depends on the diameter of the cryoablation probe. If the probe diameter is more, so it causes better crystal formation and requires less time. So this is the cryo probe, that is cannula, this is the mandrel. That mandrel portion is the active portion. And now some cases that is not operable, and we did the RFA. And this is a case of 71 years old, diabetic hypertensive with ischemic cardiac disease. So history of hemoptysis 2 months back. So diagnosed as squamous cell carcinoma. So this is the PET CT showing that active FDG uptake in that lesion. So after planning, so why RFA is preferred? Because this is a multiple comorbidity and extensive emphysema. So there is a poor PFT. So after lobectomy, that PFT will definitely get out. So our plan is to RFA only. So sorry. So अरे कहाँ जा रहे? Sorry. Yeah. So position of the RFA electrode and the immediate post-ablation scan. So this is the approach. So after the ablation, we do that regional PET CT. There is some tiny nodules of residual activity. So again, we ablate that area. After that, that is the 6 months follow-up, and that is the after 2 years follow-up. So there is a cavitation, but there is no enhancing portion at the follow-up imaging. Another case is 77 years old male complaining of chest pain and non-diabetic poor PFT. So we decided to do the ablation. So CT biopsy is a squamous cell carcinoma. So this is the pre-RFA, and this is a replacement of RFA electrodes. And after 4 years follow-up, there is only cavitation with no area or no residual lesion, no enhancement. Another case, that's CT biopsy, it is the adenocarcinoma, so primary lung cancer, 78 years old male with a persistent cough. That is on evaluation, that is a HbSAg positive cirrhosis, portal hypertension with poor PFT. So surgery will not be a good option for that patient. So RFA in view of poor PFT. So we did the RFA, and at that time, one post-ablation patient developed pyonemothorax, that hydronemothorax got infected. So we did the pigtail insertion and patient was recovered. So one study radiofrequency ablation in patients with pulmonary metastasis musculoskeletal sarcoma, that 1 and 3 year survival rate is 88 and 59%. So it is almost similar to SBRT. And another study same that 1 and 3 year survival rate, it is as good as it is survival rate is 92 and 65%. So it is safe and efficacious. And yeah, another study, radiofrequency ablation for early stage non-small cell carcinoma, it showed that 1, 2, 3, 5 year survival rate, that is approximately 78 to 100%, 53 to 86%, and 36 to 88%. So that median survival rate changes from 29 to 6 months over the time, and with the use of that ablative procedure. So any question? Thank you.
Thank you, sir, for explaining the role of interventional radiology in the treatment of lung cancer. Next talk is by Dr. Nandini from the Department of Medical Oncology in Tata Memorial Center.
Okay. Thank you. So I'm presenting this on behalf of Dr. Vijay Patil, who was unable to be here today. So the last topic, this is on more targets, more drugs, and more choices, what we as medical oncologists want for our patients. So just like we saw in the talk, 2 talks prior to this, was the different techniques of biopsies and how important it is to get a biopsy. And the main reason is because we as medical oncologists keep demanding for multiple biopsies from the radiologists. And it is because of this that we have more options and to improve the outcomes of our patients. So if you look at the way treatment has evolved in non-small cell lung cancer from over the past probably 2 decades, you can see that 20 years ago, we reached a kind of a ceiling where we would not be able to improve outcomes beyond a particular point with use of different drugs. So the hype 20 to 25 years ago was on the newer drugs that came, the taxanes and other new drugs that came over the older drugs such as the alkylators or platinums. And everybody thought that the use of different chemotherapy combinations would probably improve outcomes. But this study, which was published in NEJM 20 years ago, showed that whatever platinum doublet outcome that was used, there were 4 arms there. They used paclitaxel with cisplatin, gemcitabine with cisplatin, docetaxel with cisplatin, and paclitaxel with carboplatin. These are commonly used even today. And they saw that whatever we did, around a median survival, it was around 8 months. And this holds good till this day. We don't really cross a median of 1 year in most patients treated with chemotherapy alone. And what they saw is with all these regimens, if you look at the 1 year survival, at the most 35 to 40 patients survived, and it didn't go beyond that. The combination partner didn't matter. That is, you had to use a platinum. The other 3 drugs, they gave similar outcomes. So this is when we realized that we keep trying to switch chemotherapy regimens and do a lot of things with the chemotherapy combinations, but a doublet platinum-based chemotherapy, whichever partner you use for the platinum, it didn't really change the outcomes much. And we kind of it came to a plateau in the management of non-small cell lung cancer. So this is where molecular profiling changed the treatment paradigm in lung cancer. So this is why we want more, we need more biopsies and tissue to profile the tumor. And as time has gone by over all these years, there are multiple new targets that have been identified. So the initial target that was one of the early targets that was identified was EGFR. And EGFR now, we all know that is one of the most common targets. It has a racial or a population-based variation. In our country, it is intermediate between the extreme east and the western population, but we still have a significant number of people with EGFR mutations. So it's important to identify these patients. The importance of these molecular markers is not just for treatment. It is that these markers are drivers. They are driver mutations in the cancer. So they predominantly drive tumor growth, and blocking this pathway leads to a very dramatic response and control of the disease. So the most common markers which have targeted drugs today, and which we'll just briefly go over in this short talk, will be the EGFR, ALK, ROS1, MET, RET, BRAF, NTRK, and HER2. If you look at the most common, it will be EGFR and ALK, probably followed by MET and ROS1. RET, BRAF, and NTRK, HER2 are very, very rare. They are around 1 to 2% of the non-small cell lung cancers. So like I just mentioned, we have around, this is a data from our center itself published in 2013. The incidence of EGFR mutations in India, roughly from various papers, ranges from 23 to 29%. This is our data. There are other papers which have reported up to 29%. And like it is known, EGFR is seen more in, if you look at the these graphs, they show that they are seen more in females and non-smokers. And this fits with the profile that is known. In the Caucasian or the Western population, it's much lower. It's 10 to 15%. And if you look at East Asians like Chinese, Koreans, and Japanese, it can go up to 50%. So this is the same table which was depicted in the figure, which shows a higher number of females, never smokers, and adenocarcinomas, and females with adenocarcinoma who had higher levels of EGFR mutations in them. So what is EGFR? Basically, EGFR is the epidermal growth factor receptor, which is seen on multiple epithelial cells. It's not exclusive to lung. There are certain parts of the gene which have mutations, which are seen in lung cancer, and they can be targeted. Just to remember that a large, the 4 main EGFR exons that are looked at are 18, 19, 20, and 21. The most common, that is more than 90% of the EGFR mutations happen in exon 19, that is a deletion of a section of exon 19, or a point mutation in exon 21, that is L858R. So if you look at most of the lung cancer patients, they will have these 2 mutations, that is around 45% of each. Only around 10 to 15% of patients will have other mutations in the EGFR exon, which will be in exon 18, 20, and some of them in 21. These rare mutations have some sensitivity to EGFR TKIs, except the exon 20 mutations, that is a T790M, but now we have osimertinib, which targets that as well, and the exon 20 insertions. Right now, there is no effective drug for exon 20 insertions in the first line. There are monoclonal antibodies in trial for them. So just to remember that 90% of patients will have deletion 19 and L858R in 21, and the rarer mutations, which some of them are sensitive to current therapy. So this is most of the studies which were done with EGFR mutation patients were with geftinib with pemetrexed platinum. So that was the standard comparison at that time. So this is our study which had compared these two. And similarly, these are the various studies across the world which compared geftinib. So IPASS was the first study. Just a little bit of history about IPASS. IPASS was not designed as a study to compare geftinib in EGFR patients. It was just geftinib in all non-small cell adenocarcinoma patients versus pemetrexed chemotherapy plus carboplatin or cisplatin. And in that, they had as a planned subgroup analysis the molecular testing for EGFR mutations. And that showed a dramatic benefit. So this trial overall did not show any benefit in the whole population of using geftinib, but in the subgroup analysis, the EGFR positive patients had a significant improvement in progression-free survival. The overall survival didn't change much with geftinib. And that led to the series of other studies with geftinib and erlotinib. So you can look at this, the boxes which show the median progression-free survival with all these studies of geftinib and erlotinib significantly improve the progression-free survival, roughly double of chemotherapy. The overall survival in the earlier generation, so we have 3 generations of early EGFR TKIs, which are gefitinib, erlotinib, which are the first generation, afatinib and dacometinib, which are the second generation, and now the third generation, that is osimertinib. So the older TKIs didn't really change the overall survival of the patients. Invariably, it was similar, but the new drugs such as dacometinib and osimertinib also improve the survival in EGFR mutated patients. So we know that there's a significant benefit in treating these patients with targeted therapy. And around 1/4 of our patients are going to be EGFR positive, and it is important to test for these mutations. So we commonly test EGFR in adenocarcinomas, but EGFR mutations in lung cancer has also been noted in squamous cell carcinomas. So the typical EGFR phenotype, what we say is female non-smoker patients, may not always hold true. We have noted them in smokers as well and in squamous cell carcinoma, but the incidence is much lower. It goes up to 5%, but it has been demonstrated. And this is one of the papers from ACTREC where they had looked at a molecular profile of the squamous cell carcinoma patients, and you can see these are the various genes that they have noted in the squamous cell carcinoma, right from TP53 to other genes, including EGFR. So another gene that is seen in lung cancer, and it is also seen in other carcinomas, is the KRAS gene. This gene is in the downstream pathway, basically the RAS-RAF pathway, which is downstream of EGFR. It's a gene with poor prognostic indication. For a long time, the KRAS gene didn't have any target in lung cancer. It just said that if you had EGFR mutation and a KRAS mutation, you did worse with TKIs. And a lot of people recommended that those who had KRAS mutation should be treated with chemotherapy, and even then they had a poorer prognosis. This is recent data. This is a drug which was tested in a phase 1 study and received early accelerated approval, that is sotorasib, for a particular point mutation in the KRAS gene. And then after this, there's another drug, which adagrasib, which has also been studied. And larger trials with these drugs are ongoing, and new drugs are being researched. So just a small word which I had mentioned earlier about the rare EGFR mutations. So these are all the rare mutations: exon 18, exon 20 insertions, exon 28, L86Q, 861Q. So multiple are there, and you can get them in combination as well. Many of them have sensitivity, so you can see that they have some response to TKIs. It might be variable with each of the rare mutations. The common drug which has a lot of clinical trial data for rare mutation is afatinib, because in the Lux Lung trials, when they studied this drug, they allowed rare mutations to be included, which the earlier first generation trials excluded. So a lot of data is there with afatinib for the rare mutations. Some people consider it to be the preferred drug, but osimertinib works as well, though we don't have very robust phase 3 data. So this is the current standard of care, which actually has transformed the treatment with the benefit both in the second line setting, which was so dramatic, and then in the first line setting is osimertinib. It's a third generation TKI. And in this study, it was tested and it showed a significant improvement in progression-free survival as well as overall survival. You can see the blue line is osimertinib in all the curves. So in different settings, they have seen in the full set, in patients with brain mets, in patients without brain mets, and the overall survival. This was the initial publication, and on a follow-up publication, they showed that there was a definite around 6.5-month overall survival benefit. The advantage of osimertinib, of course, is the CNS activity as compared to the old drugs. They have very poor CNS penetration, and most of our patients usually ended up progressing in the brain with probably the extracranial disease being controlled. And also osimertinib came for the secondary mutation. So a lot of these cancers, these receptors lose certain portion of the receptor, or they change the conformation to get mutated and cause resistance to the older drug. So osimertinib was acting against the T790M mutation, and it is effective. It was developed in the AURA study for the T790M, and then they tested it in the first line setting. So it is effective in all subgroups, whether you had brain mets or without brain mets, in different performance status, and whether you had EGFR exon 19 or L858R, it didn't matter. It benefited all these patients. But there is a problem with osimertinib in our setting, is the affordability, and that is the main limitation. We offer all our patients, but the original osimertinib is hardly, probably maybe only 10 to 15% can actually afford to take it. So that brings us to how can we improve outcomes without osimertinib, and this has been studied not just in India but in other Asian countries like Japan, who also had a similar study called NEJ009, which was also released, published around the same time, where they looked at adding chemotherapy to the first generation TKI. So Geftinib with chemotherapy, it was studied in two settings. One is in our hospital, Tata Memorial Center, and the other one was in Japan in a multicentric trial. And it showed that using the strategy of targeting both the pathways, again, there was a significant survival benefit. And there was a doubling of the median progression-free survival from 8 to 16 months. And the overall survival also improved, and it was not reached in the combination arm. So Geftinib with chemotherapy is an alternative. If patients cannot get osimertinib, we often use it. But again, with multiple agents, the number of cumulative toxicities also are going to be increasing. So this is a short table which just shows an overview of the various strategies of combining a TKI plus something else, that it might be chemo, or it might be an anti-VEGF agent like erlotinib with bevacizumab or ramucirumab. So there's a little lack of long-term survival benefit with the anti-VEGF agents yet, but there is an improvement in progression-free survival. So they could be considered as one of the options. And both the Japanese study and our study showed that there is a definite progression-free survival improvement. In the Japanese study, it was 10 months, 9 months, and in our study, it was 8 months, and a definite overall survival also. The Japanese study, the median overall survival was 50 months, which is around 4 years for an EGFR positive patient, which is a very good overall survival. It is comparable or probably even higher than what was reported for osimertinib in the FLORA study, which was 38.9 months. So our first line options, Geftinib, erlotinib, unless patient is very frail or really cannot afford anything else, we use it. Afatinib is another option. Generics are available and it is affordable and not at all expensive. The other drugs are dacometinib and osimertinib. You can look at the cost and the other combination options and how we can probably offer this to patients who can't afford osimertinib. So TKI with chemotherapy or anti-VEGF agents. The next important mutation that we need to keep in mind is ALK. In Western literature, it is reported as up to 5%. In our setting, we have reported it up to 7% of patients. It is a mutation which has a dramatic benefit from targeting ALK in this group. So you can see this is some data from our hospital. And if you look at the ALK positive patients who received crizotinib, which is the green line on the figure there, versus those who didn't receive crizotinib, and you can see the survival and how much it has impacted the survival. You do far worse, but patients who received crizotinib did much better. So this was the first study. It was a phase 1, then expansion with an expansion cohort, which showed the benefit of crizotinib. And then multiple ALK inhibitors have come after that. And just to show you, this is a summary slide of all the drugs that are available. Again, crizotinib is a first generation, and then we have ceritinib and alectinib, which is the second generation, and lorlatinib, which is now a third generation drug in the ALK inhibitors. And just like EGFR, the better the generation or the higher the generation, the more the CNS activity, which is a big improvement because a lot of the survival depends on the presence of brain mets. And you can look at the median progression-free survival and the follow-up also. You can see with profile, that is crizotinib, the PFS is around 10 months. And with alectinib, it is around 35 months. So there's a significant difference. And in the alectinib, your progression-free survival is 3 years. And in the updated survival, the overall survival is a median is around 6 years. But like osimertinib, alectinib is around 6 lakhs per month. So out of reach of most of our patients. Another mutation commonly tested and seen is ROS1. So ROS1 again has a similar, it's a rearrangement like ALK, and it is also, ROS1 can be treated with ALK inhibitors like crizotinib and ceritinib. The newer generation of ALK inhibitors don't work as well for ROS. And there are some new drugs which like entrectinib, which are anti-RK inhibitors, but they have a ROS1 activity and they are in study. So ROS1 is another mutation we commonly test in our clinic. And definitely ROS1 patients, this is data from the profile study where patients with ROS1 were treated with crizotinib, and there was a 1-year overall survival of 79% of these patients, which is very good in a metastatic or a locally advanced lung cancer not suitable for any other local therapy. So BRAF is another mutation we commonly see. The V600E is the mutation that is targeted. These were early studies which targeted the V600E only with the BRAF mutations, BRAF agents, that is vemurafenib and dabrafenib. But we know that they develop a downstream pathway, MEK activation, and they develop resistance. So current practice for most of the diseases where BRAF V600E is detected is to give a BRAF inhibitor like dabrafenib with the MEK inhibitor, that is trametinib. So similarly, this is the early phase studies for dabrafenib and trametinib in lung cancer. And there has been phase 2 studies which have shown significant improvement. And now dabrafenib, trametinib is one of the approved options for use in lung cancer with V600E mutations. So the MET is the next gene. I'll just briefly go over. The MET gene has 2 types of mutations that you can see. One is a exon 14 skip mutation that is during a DNA translation and then subsequently transcription and then translation. The exon 14 is skipped and this disrupts the MET signaling. And basically, this MET exon 14 has some protein, some part of the protein which helps the MET get degenerated or ubiquitinated and cleared off. Because of the skipping of exon 14, the MET receptors in the cell are not degraded, not cleared off, and they keep remaining on the cell, and the number of receptors on the cell are more. So MET has a ligand, which is the HGF, which binds to the MET, and then there's a downstream pathway signaling, basically signals cell proliferation. So the cell keeps on proliferating and it drives the tumor. A lot of time MET mutations or like skip mutations or MET amplifications are seen in the second line setting where you develop resistance, and MET is one of the known resistance pathways for patients who have progressed on EGFR TKIs. So 2 main drugs are available, tepotinib and capmatinib. Again, tepotinib will be available in the near future, not yet marketed in India. Capmatinib also not easily available. But in case we don't have access to these drugs, crizotinib has a good MET activity and it can be used. So a significant responses are seen with the use of crizotinib as well. So most of our MET patients who don't get these newer drugs are treated with crizotinib, at least in the first line setting. So tepotinib was studied in this study where they included MET exon 14. Tepotinib study, this VISION study, did not include patients with the MET gene amplification. So this was the treatment naive group, which had a 90% of the patients had tumor shrinkage, which is not seen, such kind of deep responses are usually not seen with chemotherapy. And even in the second line and beyond setting, there were a significant number of patients who had partial response and stable disease. So this is the responses are durable in the sense that they last longer. So you have the patients in the treatment naive setting having a duration of response around 32 months, which is nearly 3 years, and a median overall survival of 29 months, which is 2.5 years. So it is a significant improvement. And even in patients who have failed 1 line of treatment and received MET in the second line, they have a median overall survival of 22 months, which is a good overall survival in the second line setting. Capmatinib is the other drug. This was a phase 1 study again, and you can see the response rates. So this basically assessed patients with both the MET exon 14 skip mutations and with the gene copy number amplification. So gene copy number more than 10, and they found that patients more than 10 had good responses. TRK, I will go in very brief. It's a very rare mutation. Less than 1% of the patients with lung cancer get it. So most of the studies with TRK, since they are rare mutation, they are basket studies. It's tumor agnostic. Multiple tumors are included in one study, and it's driver mutation based. So it's a fusion which is very commonly seen in pediatric tumors like infantile fibrosarcoma, gliomas, sarcomas, thyroid cancer, and rarely you can see it in some adult tumors such as glioblastoma. A particular type, that is a secretory carcinoma in the salivary gland, secretory breast cancer, and lung cancer and thyroid cancer. It is pretty rare. The NTRK fusions, that is fusion with another gene partner, are the ones which predict response to therapy. And larotrectinib, these are the drugs which act on it. And you can see the different colors indicate the various tumors, and they have shown the duration of response and the progression-free survival of 1 year. So 55% at 1 year remain progression-free. And this is a mixed bag of tumors because this was a basket study for larotrectinib. So this is the other TRK inhibitor, which is entrectinib. And there are newer generation of TRK inhibitors still in study. So this slide just shows the resistance mechanism, that is mutations in the gene, and then the second generation TRK inhibitors can be used, or alternative mutations that can happen off target like KRAS, MET, and BRAF, which make them resistant to the TRK fusion drugs. So this is a rare mutation, but in those who have this mutation, they get very dramatic responses to the drug. Unfortunately, both the drugs are not available in India, but if there are some trials available across the world, if patients can access them. The next mutation is the HER2 mutation. We know that HER2 is one of the important mutations in breast cancer and has a significant impact with HER2 inhibitors. So HER2 was studied in lung cancer. There is some case reports of HER2 even being seen in a familial pattern of inheritance in lung cancer. So various anti-HER2 therapies have been studied. So this is one which was presented in ASCO way back in 2018, where they studied a trastuzumab drug antibody conjugate, that is trastuzumab combined with a cytotoxic agent, that is emtansine, so TDM1, which we commonly use in breast. And these are various studies that have studied HER2 mutations. So just to note, trastuzumab by itself doesn't really have any significant improvement in survival. Second thing is that pertuzumab also didn't have any great responses. You can look at if you look at the fourth row from the bottom, the response rates were 0% for pertuzumab, and TDM1 showed some objective response rates of around 44%. So trastuzumab as single agent, trastuzumab with chemotherapy is not preferred in lung cancer, unlike breast cancer. So there's a difference in the HER2 in lung cancer and breast cancer. Also, HER2 IHC expressions do not predict anything. So if you have IHC for a HER2 in lung cancer, you really cannot use it to predict the response to any HER2 agent. It is not used. So in HER2, like EGFR, you have to look for gene mutations in the DNA. And there are particular exons, again, exon 19 and 20, which have multiple mutations, similar to the exon 19 deletion or in-frame deletion or indels, what we call in the EGFR genes. They're similar kind of mutations that happen in the exon 19 and 20. And they predict for responses to this drug. This is a new antibody drug conjugate, again, has benefit in breast. That is, if you look, there's a Destiny trial in breast and in GE junction cancers. And this trastuzumab deruxtecan has shown benefit in patients even who have progressed on trastuzumab. So this in a phase 1 study in lung cancer has shown an objective response rate of 55%. And overall survival, and now remember, this study was conducted in patients who had progressed on standard therapy, so second or third line, and in that, the overall response rate of 18 months. So there is a phase 3 study which is ongoing to see if this drug will compare to chemotherapy plus pembrolizumab in the first line setting. It has just started, so it will take time for us to get the result, but we have a target for HER2 as well. RET is another rare mutation. We know RET is one of the common mutations seen like in specific type of thyroid cancers, so medullary thyroid cancer. RET is seen in multiple other cancers as well. So just like NTRK, these studies are basket studies where they had a phase 1, phase 2 trial, which allowed all tumors, that is all solid tumors with the RET fusion to receive this drug. And then it had a phase 2 expansion cohort, which 160 milligrams was given twice a day. And again, the responses that were seen, so objective response rates in the patients who were newly diagnosed was 85%, and patients who failed chemotherapy was 64%. And this is in lung cancer. They also included patients with thyroid cancer and other cancers. So based on these early phase trials, this drug selpercatinib and the next drug tralcetinib have received approval, but again, phase 3 trials are going on. So this is another similar study where they use tralcetinib in patients with RET fusions. And this is seen in multiple tumor sites were allowed to be included. And this also showed a response rate of 61% in patients who had failed prior chemotherapy, and in newly diagnosed patients, 70%, with a progression-free survival ranging from 9 to 17 months. These drugs are being tested in a larger phase 3 trials, not available in India at present. So currently, if we have a RET mutation, we can use older drugs like cabozantinib or vandatinib, which are used for thyroid cancer. They have a RET activity. So even if we don't get these drugs, we can use them. But currently in lung cancer, in absence of access to these drugs, chemotherapy would be the first line treatment, and the other RET mutant drugs like cabo or vandatinib, we can use in second line. I will not go into the checkpoint inhibitors because we are running out of time. So just let's conclude that we know the treatment of lung cancer has changed significantly. And targeted therapy and immunotherapy has significantly improved outcomes of this disease, which previously had a very dismal prognosis. So we know the importance of diagnostic tests and biopsies and for us, because it changes our treatment. And it is one of the preventable causes, because tobacco is one of the major causes for lung cancer in our country. With this, Len, thank you.
Good evening, everyone. I'll keep my presentation brief. Don't worry. Right. It's not projected. Okay. So I'll be talking about the post-chemotherapy, post-targeted therapy, and post-immunotherapy response assessment on CT scan in lung cancer. So starting with the post-chemotherapy, so we use RECIST 1.1 criteria, which is a morphologic-based criteria for assessing response. So for using RECIST 1.1, the CT scan should be done within 4 weeks before treatment. The slice thickness should be less than or equal to 5 millimeter, and IV contrast is mandatory. So response should be assessed after at least 4 weeks and optimally 6 to 8 weeks. Eggshell plane should be used for measurement, and MRI can be used, but FDG PET CT is complementary. So if there is any discrepancy between the PET CT and CT scan, then you'll have to fall back on the CT scan. Millimeter, lymph nodes of more than equal to 15 millimeter in short axis diameter, they are considered as target lesions. So maximum we can use 2 per organ, and total of 5 target lesions can be used in RECIST 1.1 criteria. And we should make it a point to mention the series and image number in the report. Now coming to non-target lesion, any measurement other than the target lesions are non-target lesions. And of course, pleural effusion, ascites, lymphangitic spread, leptomeningeal disease, bone lesions without a soft tissue component, any non-measurable lesion node, as I already said. Lymph nodes 10 to 15 millimeter in short axis diameter is considered as pathological but non-target, and they need to be mentioned. Now, what is the criteria for progressive disease? So we should always refer to the smallest sum of long axis diameter. If that is compared to the baseline study, then we'll have to compare it with the baseline study. If it is any other smallest diameter while on treatment, then we'll have to compare with that particular scan, and which may not necessarily be the immediate prior scan. So that has to be borne in mind. And of course, the lesion should increase by more than or equal to 20%. An absolute increase of at least 5 millimeter is mandatory. Any new lesion, be it measurable or non-measurable, or there is an unequivocal progression of non-target lesions. So all these are considered as progressive disease. Now, if there's a more than or equal to 30% decrease in the lesion size, then it's a partial response. If it does not fit into partial response or a progressive disease, it's a stable disease, and resolution of all the lesions is considered as complete response. Now, addressing the dilemma. So lesions on a follow-up scan at a location which was not scanned at baseline, it should be regarded as a new lesion. Second dilemma is a default value of 5 millimeter should be given if a previously seen target lesion is not visualized on a follow-up scan. You should not give a value of 0. A 5 millimeter default should be given. So even if a short axis diameter of a lymph node falls below 15 millimeter on a follow-up scan, it needs to be measured if it was a target lesion before. And cavitation needs to be documented, although longest diameter you still need to measure based on the RECIST 1.1 criteria. Now, there are certain special scenario. If a lesion coalesces, then definitely the together measurement of the long axis diameter has to be mentioned in the report. Similarly, for lymph nodes, perpendicular to the long axis diameter, that is a short axis diameter maximum, has to be mentioned. So if a lesion fragments out, then individual long axis diameter of the fragment needs to be mentioned. Now for bone lesions, please remember that new onset sclerotic bone lesion suggests response and not a progressive disease. And both lytic as well as sclerotic bone lesions are non-measurable. Only if there's a soft tissue component associated with the lytic bone lesion, and if it is measurable fitting into the criteria by RECIST 1.1, only then you'll have to measure it and consider it as a target. Now, you can see over here that in the prior scan, the bone lesions was not visible. There was no sclerosis or lysis seen in the first scan, in the baseline scan. And on subsequent scan, you can see that new onset sclerotic lesions are visible in the sacrum as well as the ilium. So this suggests response to therapy. Okay. Now coming to post-molecular targeted therapy response assessment, this is a tricky area because RECIST 1.1 is a morphology-based criteria, and every time a size cannot be used for defining response, particularly if you are using targeted therapy, which is a cytostatic agent, unlike the chemotherapy, which is a cytotoxic agent. All right, so in our report, although still we are using RECIST 1.1, we definitely need to document the tumor attenuation value if there's a decrease in the tumor attenuation, and if there's an intratumoral cavitation. All these need to be documented in the report so that they can still continue the treatment and not stop based on the RECIST 1.1. Now, there are proposed alternatives, like we can use a CT tumor volume using the segmentation software, CT tumor perfusion, dual energy CT, diffusion MRI, FTG, PET CT, but no definite criteria or guidelines are still in place. Now, there was one study proposed by Lee using, they proposed a new response criteria using CT based on the presence of cavitation, necrosis, and attenuation changes for response assessment in NSCLC patient who underwent TKI therapy in EGFR positive patients. So generally in lung window, we measure RECIST 1.1 target lesions. All right. So, but then Lee proposed that in a soft tissue window, we only take the solid component and the cavitation part. If the lesion has undergone cavitation in response assessment scan, we subtract that from the cavitation. And then the further measurement is based on the RECIST 1.1. They proposed this. There was a difference from the RECIST 1.1 in the overall survival, but it was not that great to implement it in the day-to-day practice. Now coming to the last section, that is a post-immunotherapy response assessment. Even here, the situation is tricky. because we use I-RECIST criteria. Definitely immune response evaluation criteria is still there and documented. So why is it tricky? Because post-immunotherapy, there's 5% incidence of pseudo-progression in advanced non-small cell lung cancer. And what is pseudo-progression? That is, there is apparent increase in the tumor burden. The word apparent is very important. It's not a true increase. Apparent increase in the tumor burden after starting immunotherapy because of reactivation of immune cells. And on subsequent scanning, the size of the lesion reduces. So, which implies that it was a pseudo, that is a false progression. So, to account for that, there is I-RECIST criteria, which is in place. So, as per that, there is an IUPD, that is unconfirmed disease progression. So, if on a scan we see, response assessment scan, we see there's a 20% increase in the tumor size from baseline or a new onset target or a non-target lesion, then unconfirmed disease progression should be given in the report. We should not directly label it as progressive disease. If a repeat scan after 4 to 8 weeks shows further progression, more than 5 millimeter increase in target lesion, new lesions, whether target or non-target, only then a confirmed progressive disease should be given in the report. Now, if findings remain stable on follow-up scan, then the term IUPD has to be continued till either there's a true progression or a response. And the time, as I already mentioned, the term IUPD is given to account for the pseudo progression so that the ongoing immunotherapeutic drug is continued and not discontinued. Giving you an example over here. So in image A and B, we can see these are the baseline scans. In the right upper lobe, there is a lesion, measurable lesion, and another target lesion in the left lower lobe. So in the response assessment scan, we see, which is C and D, the lesion has increased in size. And there's a substantial increase. So IUPD should be given to this. And then on a further 4 to 6 weeks delayed scan that we see and in E and F, there's a regression of this finding. So this is pseudo progression. Now there's a term called hyperprogression. So if there's a more than 2-fold increase in the pace of tumor progression after starting immunotherapy, then it is known as hyperprogression and it is associated with worse outcomes. And please remember that pseudoprogression is associated with a good clinical outcome. So clinical condition of the patient is very important in deciding upon the change or line of management. A word about brain metastasis. Now brain metastasis measured using the RANO-BM criteria. So for this, a contrast enhanced MRI is definitely preferred. The slice thickness should be 5 millimeter or less with 0 millimeter skip. Ideally, it should be less than or equal to 1.5 millimeter. So what is a measurable disease? Any contrast enhancing lesion, which is at least 10 millimeter in longest diameter, visible on at least 2 or more axial slices, and at least 5 millimeter in diameter perpendicular to the longest diameter. And non-measurable, any other measurement which is not fitting into the measurable disease criteria, where borders you cannot reproduce, they're fuzzy borders, dural metastasis, bony metastasis, leptomeningeal disease, or purely cystic non-enhancing lesion. They all are to be considered as non-measurable. And unlike RECIST 1.1, which allows only 2 lesions per organ to be mentioned as a target, in RANO-BM criteria, for brain, 5 target lesions can be mentioned. So this brings me to the end of the talk. Thank you.
Thank you, ma'am, for highlighting the important points for response assessment scans. We welcome Dr. Amit Chaudhary, sir, Department of Radiodiagnosis from Tata Memorial Center.
Thank you. Good evening, respected dignitaries, dear friends. So mine is a brief talk about AI and lung cancer. Before looking into the applications of AI or artificial intelligence, we'll look into the AI and its subtypes which are used for imaging purposes. So artificial intelligence was a term which was first coined in 1956. Perhaps it dates back even before that. That is, if you have all seen the movie Imitation Game by Alan Turing, perhaps he is considered to be actually the father of artificial intelligence. And what do we really mean by artificial intelligence? Basically, these are computational based techniques which can mimic a human behavior or human idea or human behavior to sort of have a pattern recognition approach towards images. Next was machine learning, which was discovered or coined in 1959, which is another subset of artificial intelligence. Machine learning incorporates two types of learning, that is supervised and unsupervised. By supervised, we mean we have a training data set which has a known starting point and a known end point, and then the machine is trained or given sort of this known endpoint, which is considered to be the ground truth. And then the machine learns as to what really the expected endpoint would be. And subsequently, the machine learning or the computation goes on into the validation phase for a generating of these endpoints, where the endpoints of the rest of the validation data is not really known. Next is unsupervised learning. So here the endpoint is not really known, but what this technique utilizes is cluster-based techniques, wherein the machine sort of looks at certain similarities or similar parameters which can be encountered in the images in our use case scenario, and eventually it comes to a conclusion as to what the output can be based on machine learning technique. The next subset and most newest discovered technique in this artificial intelligence is deep learning, which involves neural networks. And what are neural networks? These are nothing but networks which are similar to the brain parenchyma, that is, which comprises of neurons and synapses. And each of these neurons in the neural network are known as nodes. So these sort of mimic the behavior of human brain to come to an inference, sort of rationalize the pictures or images which are presented. There are three types of neural networks which are present. These are the artificial neural networks, which mainly deal with number crunching and can be used in the banking or finance sector. Then there are convolutional neural networks, which mainly deal with images. Okay, so this is what would be used as far as medical imaging is concerned. And next is the recurrent neural network, which deals with the temporal set of data. That is, say for example, if one was to do a tumor tracking over a longitudinal period of time, perhaps one would have to use what is known as a recurrent neural network, an example being ResNet. So this is one such example of convolutional neural network, that is a UNet, wherein based on the convolutional neural network, one can get a very accurate segmentation from an image. We'll see a couple of examples now. So as alluded to earlier, the main umbrella category is artificial intelligence, its subset being machine learning, and further subset of this machine learning is the deep learning technology. So what are really the applications of conventional neural networks as far as imaging is concerned? This includes classification. What do I mean by classification? That is whether or not there is abnormality present or not. So if we use a classifier on a CNN, it will be able to tell you whether a given chest radiograph is abnormal or normal. Then comes detection, wherein the CNN-based artificial intelligence technology will be able to detect a given abnormality in a radiograph, whether it's an effusion, whether there's a calcification, consolidation, cavitation, nodule, cancer, effusion, pneumothorax, etc. And then eventually segmentation. So segmentation is nothing but mapping or assignment of pixels to a particular abnormality or area of interest. So as a human, it is really easy for us to draw an outline along this mass in the right lung, or as seen over here. But on using the CNN-based techniques, it involves a very research-intensive processes for actually coming out with accurate segmentation or sort of deciphering this lesion as being separate from that of the normal parenchyma. Moving on to applications, the first amongst which is deep learning based automatic detection. So at times there can be subtle masses or abnormalities which can be difficult to be deciphered by the human eye. And that is where deep learning based automatic detection techniques, that is a classifier based technique, can be used for detecting such subtle abnormalities, as in this was a retrospective study wherein this abnormality in the right perihilar location was missed by the human radar, but very well detected on the radiograph and was later confirmed to be a mass in the perihilar location in the left lung. Next comes the detection, and this is the AI-based software which is actually in action in the TMH Department of Radiology, which can give you the scores of various abnormality that it detects. That is, it will give you a score of certainty as to what that abnormality would be, whether it's an effusion, a very high certainty, in this case on the right side, or whether is it consolidation, or whether is it a combination of these two, or whether there is any extra pulmonary abnormality. Again, another case wherein at times even these CNN-based techniques can fail, wherein the technique has annotated this area as a nodule. But if you look carefully, that's actually a lead which is used for monitoring of ECG of the patient, which was spuriously detected as a nodule in the lung parenchyma. Next is tumor tracking, which can be again another method of tumor detection by using what is known as recurrent neural networks, which is applied to longitudinal data, that is applied to data at different points in time during the course of management of a patient. And this sort of unburdens a radiologist of manually measuring the tumor and assessing the response as alluded to. And its importance has already been emphasized in the previous talk by the earlier speaker as to why do we need to measure and give those measurements as far as whether there is progressive disease, whether there is partial response, or whether there is complete response. And segmentation, as alluded to before, is nothing but mapping of pixels to an abnormality. And this involves mapping out a lesion very accurately. Again, can also be used in tumor tracking, just like detection techniques, but with far more accuracy, can give us volumetric measurements, which can be used longitudinally and which can perhaps be a more robust measure or parameter of giving tumor measurement compared to a unidimensional measurement. Next is AI-based dose reduction technique, which is again another work in progress, wherein we can see that there is a low dose CT which has been acquired, and we can see that this image is very grainy, that is, it has poor signal to noise ratio. But by using CNN-based upsampling techniques or noise reduction algorithms, we can see that we have a CT image which has far more better delineation, has sharper margins, and lower noise in this image. Again, you can also appreciate that these streak artifacts emanating from the bone on the left side are significantly reduced using CNN-based dose reduction technique. As emphasized by Dr. Kunal in his talk, it is quite pertinent to have low dose, that is low kV, low MS CT, especially in biopsy studies, because we know that these studies have certain degree of radiation exposures, which by means of stochastic effect can lead to accumulation of the dose and can have certain hazardous effects like second cancers or even hereditary changes and mutation. Next is another example from literature wherein the classifiers can be further improvised such that the abnormality in the lung tumor can even be attributed to a particular mutation. Say, for example, whether there is EGFR mutation in a given tumor, which again has implications as far as management of patient is concerned. And this has been shown to be quite a new promising technique as far as CNN or deep learning of the lung cancers is concerned. Moving on from imaging to pathology, again, artificial neural networks, or rather convolutional neural networks, have a big role as far as whole slide scans reading is concerned. This is especially true in the setting of frozen section or giving an intraoperative diagnosis, because at times it can be really difficult without the use of immunohistochemical techniques to come down to a diagnosis, accurate diagnosis on frozen section and intraop settings. And this is where CNN-based technique can be utilized or can be leveraged to give a better diagnosis. Likewise, it also increases throughput of a pathologist by augmenting his or her abilities of giving the diagnosis in a shorter duration of time and also to a better accuracy. Then the new kid on the block as far as artificial intelligence is concerned is what is known as federated learning. This is nothing but something like shared learning. So what happens in federated learning is that a CNN model is developed or trained at one given institute, and it is this model which can be distributed to other institutes in the network, such that the model undergoes training on a newer data set at those newer institute areas. And again, this model is what is shared back to this central server, so that one comes to what is known as a consensus. So that whenever we have this newer model which now encounters, say, a newer pathology or pattern type, it can very well recognize that pattern even when that comes to an area which is not really endemic to that set of disease in a scenario. So that is the new kid on the block, which is federated learning, which also involves transfer learning. And that is a really brief and very oversimplified view of artificial intelligence. And I thank you all for your time and attention. And I'll be happy to have any queries. None. Thank you.
Thank you, sir, for simplifying this complex topic of AI. We now move on to our next session of case presentations by the residents, which will be moderated by Dr. Suryaveer, Fellow in Thoracic and Abdominal Imaging at Tata Memorial Center.
Good evening, everyone. I shall be moderating the best thoracic case session. May I please invite Dr. Virendra, Assistant Professor, Department of Thoracic Surgery at Tata Memorial Hospital, and Dr. Nivedita, she's also an Assistant Professor in Department of Radiology at Tata Memorial. We have a few submissions from budding radiologists. So may I please invite Dr. Mansi to present her case.
So good evening, everyone. I'm Dr. Mansi from Tata Memorial Hospital, and I'd like to discuss a case where we discuss the midline tracheobronchial tumors. A 40-year-old female came with chronic cough and breathlessness. She developed stridor, where she presented to the emerge. A contrast-enhanced CT thorax was done, which revealed a mid-tracheal growth 3 centimeter proximal to the carina, which abutted the anterior esophageal wall with no infiltrations. There was no associated mediastinal adenopathy or supraclavicular adenopathy. At this point, we would like to give some differentials. So any volunteers from the audience? So the differentials we thought were some malignant tumors like adenoid cystic tumors, arsenoid tumor, or squamous cell carcinoma of the trachea. And there may be some benign tumors also, like hamartoma or leiomyoma of the trachea. Then a PET CT was done, which revealed high uptake in the trachea. SUV max was 11,091. So we narrowed it down to two differentials at this point of time, which were adenoid cystic, squamous cell carcinoma, and mucoepidermoid tumor. But as mucoepidermoid and carcinoid show low FDG uptake, squamous cell carcinoma has high FDG uptake. So only one differential was there, that is squamous cell carcinoma. Then the patient underwent multiple hypoxic episodes. So she underwent a fiber optic biopsy which revealed poor differentiated squamous cell carcinoma. On IHC, the tumor was positive for P40 and NUT. The patient underwent debulking surgery outside. Patient received RT and chemotherapy with concurrent paclitaxel and carboplatin. And after that, R1 resection was done, and the patient underwent tracheal dilation and stenting multiple times. Silicone stent was put. So NUT carcinomas, formerly known as NUT midline carcinomas, are a rare and very aggressive form of cancers in the body and occur in the midline structures. It occurs all over the world in adults and children and both sexes. There is no NUT carcinoma is undifferentiated and poorly differentiated squamous cell carcinoma. And it normally lines the hollow organs in the body, such as the respiratory tract. It is characterized by the rearrangement and translocation of NUT-M1 gene, and there is translocation of the chromosomes 15 and 19. NUT on chromosome 15 is translocated to BRD4 on chromosome 19, forming a BRD4 NUT fusion oncoprotein, which causes activation of MYC, causing uncontrollable growth of the squamous cells in the midline structures of the body. On CT, NUT midline carcinoma typically appears as a hypoattenuating, heterogeneously enhancing infiltrative mass with poorly defined margins, and has the propensity to invade adjacent structures, including the heart, pericardium, esophagus, central airways, and vessels. Investigation of choice is PET CT, which shows intense FDG uptake with high SUV, and final diagnosis by biopsy, HPR, and IHC evaluation. So these are various differentials. So primary malignant tumors of the respiratory tract are surface epithelium. We have squamous cell carcinoma, neuroectodermal tumors, neuroendocrine tumors, adenocarcinoma, salivary gland tumors like adenocystic CA, mucoepidermoid, then mesenchymal tumors like sarcoma, lymphoma. So these are the pictures. Squamous cell carcinoma is an ill-defined growth which is sessile and comes from the squamous cells of the trachea. It shows intense FDG uptake. Neuroendocrine tumor also occurs from the neuroendocrine cells, and it shows low FDG uptake. Basically, all the tracheobronchial tumors are differentiated on the basis of PET scan. And there are also benign conditions which arise from the epithelium, like squamous cell papilloma, papillomatosis, salivary gland tumors like pleomorphic adenoma, gland adenoma, oncocytoma, and mesenchymal tumors like hamartoma, leiomyoma. Yeah. She had the disease. Silicone stent has lesser. She had severe stridor, so stenting was done. Yeah, she underwent serial dilation before the stenting was done. Yes, yes.
Dr. Unnati from Tata Memorial Hospital.
This next.
Good evening, everyone. Myself, Dr. Unnati Chokse from Tata Memorial Center. Today, we'll be discussing a case report of a rare mediastinal mass and how did we arrive at the diagnosis. So our patient was a 21-year-old male from Bangladesh, and he presented with fever, persistent productive cough, and breathlessness, which was more on lying supine. So on imaging, we had this image of the CT scan, which showed a homogeneous mass occupying the anterior mediastinum with lobulated margins, and it was more of homogeneous, and it was non-evident on PET scan. And when the patient arrived at our center, he already had undergone a biopsy at his native place, which was suggestive of a thymomoral Hodgkin's lymphoma. This biopsy was reviewed at our center, and there were no malignant cells found at our center for this biopsy. So so this was a discordant case. The imaging features at our center was not in concordance with the previous biopsy which he underwent in Bangladesh. So next, we to better characterize the lesion, we did a MRI for this patient, and the lesion was very extensive in nature, and it was T1 hypointense, and it did not enhance, and it was T2 hyperintense on imaging. And the MRI was done, which showed T2 hyperintense in extensive anterior mediastinal mass with no internal post-contrast enhancement. And it was extensive disease extending into the neck spaces. So thereafter, actually, we went for a repeat biopsy at our institute, which revealed it to be a thymic cyst. But after the biopsy, the patient had developed a complication. There was a new onset pericardial effusion in this patient, and which was drained and found to be chylous in nature. So next, we suspected a lymphovenous malformation because of the extent of this lesion and the development of pericardial chylous effusion after the biopsy. So we doubted the diagnosis of thymic cyst, and then intranodal lymphangiography was done, which showed the communication between the mediastinal mass and the thoracic duct. So subsequently, thoracic duct cannulation was done, and angiogram was done, which demonstrated the communication between the mass and the thoracic duct. This was later completely embolized. The thoracic duct was embolized using 33% glue, and then there were subsequent 2 settings for sclerotherapy with bleomycin of the thoracic duct. The patient improved in condition after these treatment procedures, and he was later discharged and is now on follow-up. So the teaching points in this case are that lymphangiomas are rare benign tumors which can present as large mediastinal masses. And when a lymphangioma is suspected, a MRI should be included in the early set of investigations because it better characterizes lymphangiomas. They appear T2 bright, T2 hyperintense, and they don't show any enhancement. MRI, along with other clinical features, is of paramount importance in ruling out the differentials and coming to a diagnosis. In spite of a negative biopsy result, sometimes these lymphangiomas can lead to a negative biopsy result. And in case of suspected veno-lymphatic communication, a lymphangiogram should be done to confirm the location. And glue embolization and sclerotherapy procedures in intervention radiology yield excellent results in such cases. Thank you. No, they're different. So this was a lymphangioma actually, but it was not proven on SPR. Actually, we had a different diagnosis of thymexis. So MRI was more of benefit. Thank you.
Next is Dr. Tanvi Shinde from Sion Hospital.
I'm Dr. Tanvi, third year resident from Sion Hospital. Today, I will be presenting a very simple yet interesting case in front of all of you. So recently, on 5th of July, we had a patient, 63-year-old, who presented to us with main complaint as an headache. He was having headache since last 4 months, which was unbearable since last 15 days. On further evaluation, there was no other complaints, no other neurological signs and symptom or any other systemic illness. Patient was a non-alcoholic and non-smoker. So patient was admitted under medicine, and then as a first investigation, CT brain was performed on same date, that is on 5th of July. So these are plain CT images. Here we can see multiple hyperdense lesions, which are well defined with surrounding hypodensity, likely vasogenic edema. And these lesions are found in mainly at gray-white matter junction, like they were at the frontal region as well as in cerebellar vermis and in left parietal and temporal region. So to further characterize lesions, we went ahead with contrast CT. So on contrast CT, these lesions show vivid enhancement with few hypodense areas which were non-enhancing, mainly at the center of these lesions. So on the basis of these characteristics, a diagnosis of metastasis was established. As these lesions were hyperdense on plain scan as well, we suspected it to be an hemorrhagic mets. Now, as patient absolutely did not had any systemic symptoms, we went ahead to search for the primary, and we advised some basic investigations like chest X-ray, USG abdomen, and so on. So very first investigation which was done immediately on 7th of July was chest X-ray. And we got a surprising picture after that. because this is a frontal chest radiogram of same patient, which is showing a relatively well-defined radiopacity in the right perihilar region. Mild elevation of right dome of diaphragm is also noted, and it is actually obliterating right heart border. So as this was highly suspicious of malignancy, we went ahead with contrast enhanced chest CT on very next day, that is on 8th of July. So these are some CT images which I have, plain as well as contrast images. So here we can see a spiculated margin soft tissue density lesion, mainly in the right perihilar region. It is involving anterior segment of right upper lobe as well as right middle lobe. It is showing heterogeneous enhancement with few hypodense areas which are noted within, which are non-enhancing. Now, these are some arterial phase images. In first image here, we can see pulmonary artery, and the tumor is seen invading into it with non-opacification of its branches, which is actually suggestive of tumor thrombosis. Then here in this picture also, again, we can see pulmonary artery, and there is actually non-visualization of non-opacification of its branches. Then in this image, we can see some small vessels, which are actually arising from descending aorta, and they are traversing in right pretracheal and paratracheal region to reach this right pulmonary artery. These are actually MAPCAs, and these are formed because of severe obliteration of pulmonary artery. Now I have some more contrast phase images. Here in this first image, you can see a superior pulmonary vein, which is draining into right atrium. So the tumor is seen invading into the superior pulmonary vein, which again suggested a tumor thrombosis. Then in these images, we can see SVC, and the lesion is seen encasing the proximal segment of SVC till its opening into right atrium. SVC is severely narrowed, but we can see contrast opacification. These are some lung window images. So this is a main lesion, and surrounding lung parenchyma shows interlobular septal thickening, which is somewhat nodular, and it has few granulous opacities. So these features are actually suggested that the tumor has now invaded into lymphatics, that is, as we call it as lymphangitis carcinomatosis. On further evaluation and on further screening of lung parenchyma, we found a pleural tag with a heterogeneously enhancing satellite nodule, which was in the lower lobe. The main lesion was seen in the upper and predominantly in the middle lobe. So this lesion was in an altogether different lobe from primary lesion, and it had a feeding vessel to it. So it suggested that it is a type of metastatic pulmonary nodule, which is synchronous with the primary. These are some virtual bronchoscopy images. So first image is taken at the point of carina, where you can see carina and right and left main bronchus. Then we went ahead into the right main bronchus, and this smooth margin lesion you can see, which is obliterating the bronchus. So overall, the diagnosis was of bronchogenic CA, but this patient had some other features with it. That is, he had tumor thrombosis invading into RP, right pulmonary artery, and right superior pulmonary vein, as well as the patient had lymphangitis carcinomatosis, and he also had a metastatic parenchymal nodule. To confirm diagnosis, we referred this patient to respiratory medicine department, who performed bronchoscopy-assisted biopsy for this patient, and histology reports were suggestive of squamous cell carcinoma. To complete the study and to confirm our hemorrhagic METS diagnosis, which we gave on CT, we went ahead with brain MR. And these are some brain MR images. On FLAIR, these lesions were iso-intense with surrounding hyperintense vasogenic edema. These lesions, they showed restriction diffusion with corresponding low ADC. On contrast MRI, they were again vividly enhancing, and few lesions also showed non-enhancing hypointensities within. The surprising thing was, on FFE images, these lesions were not having any kind of blooming. So this diagnosis of brain metastasis was confirmed, but they were not hemorrhagic METs. Now, bronchogenic CA is not very uncommon. We see it often, but this case was different because there was a glitch, diagnostic glitch to it. This patient, in spite of having so much extensive spread into the major mediastinal vessels, as well as he was having lymphangitis carcinomatosis and metastatic pulmonary nodule, he absolutely had no just signs and symptoms. In fact, he presented with the neurological symptoms, and clinicians thought it to be an SAH, so primarily CT brain was performed. So this case was a different case, and we needed an intensive hunt for it. But just because of a basic investigation like chest X-ray, we got an immediate hit, and we reached to the diagnosis in less than 1 week time. So that's it. Thank you.
Respected judges will select the best case. They will select it based on how good the case was, how interesting it was, and how well it was presented. The winner will be emailed, will be notified through email. Now with the panel discussion. With the multidisciplinary tumor board meet. This will be moderated by Dr. Virendra. He's an assistant professor in the Department of Thoracic Surgery. And the panelists will be Dr. Nivedita from Radiology, Dr. Kunal Gala from Interventional Radiology, Dr. Naveen Mumadi from Department of Radiation Oncology, Dr. Rajiv Kaushal has joined us online, and Dr. Devyani from Surgical Oncology.
Thank you and good evening, everyone. So Dr. Kunal has come, so we'll start. Yes, esteemed panelist. So let's start our first case. It's so we don't have much time. We'll discuss two cases and try to cover as much as possible. This is a 73-year-old male with the ECOG performance status of 1, never smoker, hypertensive, diabetic, past history of pulmonary TB and extrapulmonary tuberculosis, also left femur, 4 years back. Presented with cough since 4 months. Effort tolerance is 1 flight, limited because of this femur surgery, and he is walking with help of stick. So these are the images. I would like Dr. Nivedita to opine about the images with the available pictures. If you want me to go back, let me know. Yeah.
So I can see a speculated mass in the right upper lobe, along with the background of a lot of fibrotic changes. And I think there's a loculated effusion as well in the on the right. And it is showing some kind of enhancement. Can you go to the next slide?
Yeah.
So definitely there's showing some kind of enhancement also, the lesion with associated pleural reaction. So it looks suspicious to me, the right upper lobe mass.
Okay, what is your opinion about rest of the parenchyma? How does it look?
So since the patient already has a history of tuberculosis, I believe the rest of the lung parenchyma shows the post-infective sequelae.
Okay. This is what we got the report also. I would like to ask Dr. Devyani. So Devyani, a radiologist has reported as a suspicious lesion. So do you need a biopsy, or you go ahead with that report and move ahead with for further workup, or do you need to confirm that thing with biopsy?
I would like to confirm with the biopsy in this case, especially since you said that Paul uses a walking stick, the lung parenchyma doesn't look great. So if it was something which was going to be a quick in, quick out surgery where you can send the budget out, send it for frozen, and then decide your further management, that's the only possible scenario in my mind where we can avoid a biopsy. But in something like this, where I'm questioning the decision of surgery in my mind in the first place, definitely biopsy.
Okay. And what is your opinion about the small loculated thing? Will you evaluate that also, or you'll ignore because there is a lot of other infective changes in the adjacent lung?
I agree with the point of view that with the amount of infective changes in the rest of the lung, the little bit of pleural effusion most likely might be reactive, but price to pay to just tap that effusion since you're anyway going in for a biopsy. But in the rare case that it comes positive, it's going to change our management completely.
Yeah.
So I think if you're anyway going in for an interventional procedure, this is
Why not
this
tap
can be
that
done
and
in
get
the
a
same way.
cytology? Okay, fine. So we did the biopsy, and this is what report we found. So I think Dr. Rajiv is also there with us. Sir, can you just briefly for the audience describe what important immunohistochemistry marker do you look into to characterize different type of NSCLC?
So when we when we get the biopsy tissue,
is he there on Zoom or no?
Yeah, so now I can't see the screen. That is the problem, but it's okay. So when we get the biopsy tissue, so first thing is we have to confirm the diagnosis of malignancy, if it is there or not. So if it is malignancy, then type of tumor, non-small cell versus small cell. And if it is a non-small cell, we have to categorize it to adeno versus squamous. That is the most common tumors. So if the morphology is very classical and it's showing nice glandular component or nice squamous areas with keratinization, there's no need for even ISC. You can save the tissue for molecular analysis. But if you're not very clear on the morphology and there are typical glandular or squamoid features are not there, then in that case, we need to perform ISC, and minimum panel of ISC is done in the lung, that is TTF1 or napsin for adenocarcinoma, or P63 or P40 for squamous markers. So out of that, P40 and TTF1 are relatively preferred. They are more specific as compared to P63 and napsin. So these are the minimum. If you have to ask minimum markers, TTF1 and P40 are to be done.
Okay, sir. Thank you. So I would like to take Dr. Kunal's opinion also, because this guy has a very bad parenchyma on scan. So when you are planning for a biopsy, are you more worried about, is there a higher complication in a patient with such lung changes, or it's the same compared to others?
Yeah, definitely there is more chances of pneumothorax, so need to counsel regarding the same thing. Might develop a pneumothorax, and drainage, the small bore drain could be required, needs to be counseled prior to doing biopsy.
Okay. So we need to be more precautious and be more vigilant about post-procedure complications.
With small volume lung, so those are high risk for
biopsy.
pneumothorax.
Okay. So I'll come to Dr. Naveen. He's a radiation oncologist in our center. Sir, now we have seen images. What staging workup will you ask for?
I would ask for a PET CT scan in this patient, and that will complete the metastatic workup. And in all patients who are being planned for any radical treatment, we would also get an MRI of the brain.
So is there any situation where you can avoid or MRI brain, or you'll go and ask for all patients?
So typically in patients who have peripheral small tumors, we generally can probably avoid not getting a PET CT scan. But in this patient, I would probably err on getting the PET CT scan then, because he has a lot of infective changes also. So give me an idea as to what exactly we are dealing with.
Okay. So we did PET as well as MRI in this case, and it was same what Nivedita pointed out earlier. It's a T1 peripheral lesion with no other disease anywhere. Even MRI brain is clean. So I'll come back to Devyani. You have seen images, PET is non-metastatic. You have seen patient also imaging findings. So what is your further plan? Where is the patient heading towards? Which kind of management do you think? Like, will you ask for any other functional evaluation to decide treatment, or you can take a call based upon the imaging finding?
Based on the way you describe the patient's clinical status and looking at the lung fields, surgery looks a little bit unlikely and a little bit of a far-fetched treatment plan for this patient. But we wouldn't take this decision without a pulmonary function test in the first place, because I think the only other option would be sending the patient across to Naveen, and Naveen would require a pulmonary function test.
So yeah, Dr. Naveen, you will need PFTs, or you are fine? Suppose patient is planned for a non-surgical management. So will you need PFT, or how do you go ahead with that?
So although most of the times we are left with patients who are handed down by the surgeon, typically patients who are inoperable medically, we still would get a PFT DLCU and read into it, basically because one, we have a baseline idea about the patient's lung function, and so that we can kind of predict what his functions may turn out to be post-radiation. Although we do claim that post-SBRT, the dip in pulmonary function is pretty minimal. But in patients who have a baseline very poor pulmonary function test, even that small dip might actually throw them completely overboard. So I would want to know baseline what we are dealing with, so that it also helps me to counsel the patient as to what side effects
So
is to
do you
expect.
keep
So
any cutoff, like below this you will not give treatment
again,
SBRT?
yeah, so like how you guys have for surgical, how you predict a post-operative predicted values of FE1 DLCO and kind of have a threshold as to where you will and not operate. We do not have, again, for the same reason that we deal with hand-me-downs most of the time, but still we do SBRT in patients who have pretty poor PFT. But we don't look at the PFT DLCO values in isolation. We do look at what is exactly the pathology behind the poor pulmonary function test. Especially in patients who have interstitial lung disease, we are doubly cautious, because in those patients, SBRT can actually lead to worsening of their symptoms also, not just the PFT DLCOs. But if there is some other some other pathology, for example, this patient has a post TB sequelae, which might be the reason for his poor pulmonary function test, there I'm a little more confident that my treatment might not actually cause too much of issues.
So are you comfortable in giving SBRT to this guy, or you will look into PFTs and then decide?
I would still look at the PFTs for the reason that I said, that I would want to know what the baseline values are, and I'm okay doing RT for this.
Yeah, so we discussed in MDT and patient was planned for SBRT, he underwent also and is fine in follow-up. I would like to take Dr. Kunal's opinions. What is your opinion on treating peripheral T1 N0 NSCLC with the RFA or other RFA or microwave kind of in a medically unfit patient?
Yeah, so we have three modalities as of now. Two are heat-based therapy, like RFA and microwave, and third is a cold-based, like a cryo ablation. So these are proven to if the then it is much more beneficial, because it does not affect the PFT at all. We take 1 centimeter margin as similar to the surgery, and the curative intent with 1 year, 2 year, and 3 year have shown to be beneficial.
Okay, so we have other modalities also, not only SBRT. So this patient underwent SBRT and fine on follow-up. Now next case is a locally advanced. It's a 63-year-old lady with good performance status. ECOG1, effort tolerance is also good. 3 flight, former smoker, hypertensive, presented with cough, dyspnea, and right-sided chest pain. On examination, it was fine. There was no supraclavicular adenopathy. So again, these are the imaging. I would like to, again, Dr. Nivedita's opinion. What do you see here? What is your view on the available pictures?
Yeah, so I can see a right upper lobe mass, which is actually infiltrating the chest wall, because I can see rib erosions. So it's a, yeah, it's a chest wall infiltrating suspicious right upper lobe mass. And in the given mediastinal window, I'm not seeing any node.
So in this picture, I think we are clear about chest wall involvement. Suppose you have a doubt about parietal pleura or chest wall. So do you have any other investigation which you ask for, or how do you go ahead with that? Or
I
CT
think
scan is enough?
chest CT scan is enough for commenting upon the pleural involvement and even the bone involvement, because here chest wall involvement, we would get an idea from the adjacent bone erosion and you know, whether there's lysis and a soft tissue component associated. So the best imaging modality is a chest.
CT chest. Okay, okay. So this patient also had a complaint of pain over the chest wall area. Most of the time we take control of that with medicines, oral medications. But suppose, Dr. Kunal, if it is not settling, can we offer anything to take care of pain by the time patient is undergoing preoperative evaluation or other workup?
RFA or ablation has been proven for pain palliation as well. So we can...
No, not the primary. Suppose we don't want to touch the primary. Okay. Primary may be tackled based upon staging workup later on. So can we do anything for pain without...
So now block with lignocaine and bupivacaine, and then later on to steroids so that the pain is relieved.
Okay, okay.
Recently, we started referring quite a few of these patients to you guys for the nerve blocks, and it's worked very well for us. So do you give a short acting before and see if it works?
Yeah, if it works, then we get it.
Okay, so you start with a lignocaine and then go on to steroids. And with steroids, how long is the pain relief? It's a neurologist.
Great, great. So we won't discuss about staging workup and function evaluation that we have already covered in the previous case. We did PET scan. It was right upper lobe lesion involving third and fourth rib with few medicinal adenopathy, and MRI brain was fine. Dr. Devani, do you need any kind of medicinal staging in this case, and what modality will you prefer?
Yes, definitely. It is a largish lesion, though it's pedicle. And I don't think that we saw any images in the PET showing up any very suspicious looking nodes. But even then, this is definitely a candidate for invasive mediastinal staging. So if we go by strict guidelines, it would be EBUS first and a negative EBUS confirmed with a mediastinoscopy. But time, cost, and logistics permitting would be both these. If I had to pick one, I would definitely at least go ahead with a mediastinoscopy, which is still the gold standard. Probably at the same time as the surgery, send the nodes for closing section analysis. If they're negative, go ahead with surgery under the same anesthesia.
So if you have both modalities available, time also, then how will you?
EBUS
followed by mediastinoscopy. Okay. So we did same in this guy also. We did pulmonary function test. PFTs were fine. 2D-echo was also okay. EBUS was negative for any mediastinal node. So it was clinically T3, N0, and M0 disease. Dr. Naveen, what management option can you want to go ahead with in this patient?
So if this patient is functionally otherwise fine, going with a pulmonary function test, he is a candidate for surgery also. So surgery is the first option that I would also choose for this.
So again, coming back to a surgeon. So suppose this patient has a chest wall involvement. We saw PFTs, we calculated predicted post-operative values. So how do you account for the additional loss because of the chest wall resection? It's lung that we have calculated for, but how do you take that into consideration? Or
yes, definitely, because it's not just the lung parenchymal loss that the patient is going to have to deal with a part of the chest wall gone, and in this case, it is a significant amount of chest wall. We're looking at least at 2 to 3 ribs and a lateral effect. So it's going to interfere with the bucket handle motion of the patient's respiratory mechanics. So I don't think there's a fixed number to it, but somewhere between 10 to 15% is the value that if you have to put a value to it, that you would lose additionally. And the point that we need to be careful here is especially if it's a person with borderline lung function, plus a lung resection and a chest wall, we have to be aggressive with reconstructing the chest wall at the time of surgery.
Okay. So point well taken. So PFT loss, there is no clear-cut, mathematical formula as far as chest wall loss is concerned, but obviously we have to take that also in account. So this patient underwent surgery and with chest wall resection and upper lobectomy with SMLND. I would like to ask Dr. Rajiv, suppose a surgeon is a little bit, doubtful and he sends full specimen to you for a margin assessment on frozen. How comfortable are you in, commenting upon chest wall margin on frozen?
Yeah, so the margins which we, for any lung surgery, which we commonly sample, they are either parenchymal cut margins or bronchial cut or vascular cut margin. And if, as in this case, there is a chest wall involvement is concerned. So there can be two margins from the chest wall. It can be either soft tissue margin or the bony margin. So soft tissue margins we can sample in the frozen, but bony margins are difficult to process in frozen. So other alternative is if you really want them, the bony margins, we can make the marrow imprints and evaluate them. So that is the other alternative to, but bones sample we can't process in frozen. We can process the marrow, but not the bony margins.
Okay, so we rely on the soft tissue around bone and if needed, bone marrow imprint. Okay, sir. So this patient underwent surgery. HPR is T3N0, moderately differentiated squamous cell carcinoma with involvement of chest wall. I had a few questions about medical oncology, but I don't think we have Dr. Vijay in our panel. So, Dr. Naveen, what treatment would you like to, if you
Before
can?
I go into the adjuvant treatment, I think I kind of made your job easy by when you asked me what management you would do, I said surgery and not CTRT. So probably just for the sake of discussion, I would take that and then talk about the adjuvant treatment. So T3N0 patient, although I said surgery, but if the surgical morbidity is significant, then CTRT is definitely an option. We have level 1 evidence to say that probably even in resectable patients, chemo-RT is a reasonable approach to. And given the fact that this patient has squamous cell histology and rib erosion, and we do see that these patients do respond both radiologically and symptomatically well to RT, it's definitely an option.
Okay.
Having said that, now that this patient has undergone surgery with a more than 4 centimeter lesion, and can we just have a look at this? Yeah. So all nodes negative, but the patient has a T size of almost 7 centimeters. So this patient definitely warrants adjuvant chemotherapy. For the sake of the audience, all patients with node positive disease receive adjuvant chemotherapy, platinum doublet for 4 cycles. And patients with any tumor more than 4 centimeters, even N0, also benefit with adjuvant chemotherapy, as large trials have shown this. Postoperative radiation has been always discussed in the setting of node positive disease, especially mediastinal nodal disease. However, in light of the recent publication of 2 major phase 3 trials which have evaluated postoperative RT in N2 state disease setting, has shown that probably we have kind of overestimated the effect of radiation in this patient. So standard treatment for this patient is adjuvant chemotherapy for it.
And what about chest wall? If chest wall involvement is there and suppose margin is negative, is there a role of RT or
as long as the margins are clear, we are okay, because this patient has a higher risk of systemic failure. But in patients who have positive margins, close margins, then definitely there is a indication for giving postoperative CTRT.
So that is what happened here. Also received 4 cycles of platinum-based chemotherapy and was on regular follow-up. I think we are done with our panel. 2 cases. Thank you very much. Thank you.
So with this, we end the radiology workshop for today. And it gives me great pleasure to extend a vote of thanks to all those who made this event successful. First and foremost, we would like to thank Dr. Kumar Prabhash, Head of Department of Medical Oncology, Dr. Vanita and Dr. Vijay Patil for their initiative and immense efforts in organizing a conference of this magnitude. On behalf of the entire team, I wish to extend my heartfelt gratitude and regards to all the speakers, starting from Dr. Bhavin, Dr. Ashu, Dr. Mandeep, Dr. Sayak, Dr. Rajiv, Dr. Kunal, Dr. Devyani, Dr. Sabita, Dr. Naveen, Dr. Falguni, Dr. Nandini, Dr. Nivedita, Dr. Amit. And I'm also very grateful to Dr. Amit Janu sir and Dr. Suresh Kulkarni sir for their active efforts and constant guidance and support in the planning and execution of this conference. I would also like to thank Garima and Surbhi for constantly coordinating, and they've been extremely helpful in this workshop. And it would have been impossible to have conducted this hybrid conference without the perfect coordination with the IT team and the event management team. Please forgive me if I've missed anyone. Thank you very much.